यार कहाँ गया?
Hello. Dr. Praful, can you hear us?
Yes, ma'am. We can hear
Okay.
clear.
Can you hear Dr. Tushar's voice?
No, we cannot hear Dr. Tushar's voice.
Karan,
We're just trying to set it up.
हेलो करण,
सर
ये डॉक्टर प्रफुल्ल का आवाज बहुत लाउड है.
अच्छा मैं कम कर दूँ.
Good morning, sir. Good morning, Dr. Tushar.
Praful, can you hear Dr. Tushar's voice?
No, we cannot hear Dr. Tushar's voice.
Dr. Tushar, can you try speaking again?
दूसरा
सर बोलिए सर.
Praful, can you hear Dr. Tushar's voice?
हेलो.
Hello.
Dr. Tushar, could you please try speaking again?
No, we're trying to set it up. I think the voice is not Karen.
Sure.
Not yet. Yeah.
आ रहे. किसका पी कर है? बोलो. हाँ. तो
हाँ जी भाई साहब.
हाँ. बोलो जरा.
Can you hear me now? Dr. Praful?
हाँ.
check. Hello. Dr. Praful. Hello. Ma'am,
Yes,
आपको
doctor, we can hear you. Yes, Dr. Tushar, we can hear
अभी
you.
उनको उधर से बात करने दे. रमेश, उनको भी उधर बात करने दे.
Praful, this is Tushar here. Can you hear me now?
Yes, sir. Good morning, sir.
Huh?
Yes, Dr. Tushar, we can hear you.
Okay.
Hello. Yeah. Good morning, sir. Dr. Lomi here, sir.
Wait, huh?
Hi, Dr. Tushar. Good morning. This is Diksha this side. Can you hear us?
Go then.
Dr. Tushar and team, can you hear us?
Yes,
Yes, we can hear
we
you.
can hear you.
Okay, perfect. So, sir, I hope you're ready. We'll be starting in 2 minutes from now.
हाँ हाँ बोलो बोलो। थोड़ी पकड़िए, थोड़ी पकड़ो, थोड़ा ऐसे करो। लाइन में
The context up for our online audience as well. And then
Praful,
we
I'm
can
going to
get
start
started.
now.
Yes, sir. You can start, sir. We can see you.
So this is a slightly large pterygium which is going towards the fornix, primary pterygium. So we have given some perivalvular block. I'm going to supplement it. So we'll do a excision with conjunctival autograft with fibrin glue.
Can we see the surgical view, please?
Sorry.
Yeah, we can see now. Yes, sir.
So I marked the area which I'm going to be excising finally. Xyloartery.
Sir, is it the plain BSS that you injected or it contains adrenaline and xylocaine? So this is a normal Sinsky hook you are using to lift the
Yeah, yes,
head.
yes. You can see we have got some cleavage plane here.
Yeah, we can see a nice plane.
Yeah. So you'll see that the limbus involvement is actually less than what the pterygium is looking like. So one sort of this was the
We could see a lot of fibrosis. It must be a very long-standing case.
Yeah, it's quite advanced. Thought we'll do an advanced case this time. So this is the head coming out. Soft stick is over. देखो. This is the subconjunctival overgrowth. Can you see the?
Yes,
Yes,
sir.
sir.
Clearly
Yeah.
visible.
So the idea is to pull it out and excise it as far as possible. I'm going to do some cautery. There's quite a bit of bleeding here. वो ले लो, saline ले लो बच्चे. करो.
What's your approach towards the tenons? Do you just
बढ़ाइए।
remove your approach towards the tenons tissue? Do you remove just within that
बढ़ाओ,
pterygium
करो,
cap,
wash करो,
or you would like
wash
to
करो।
pull it and
नहीं,
remove as far as possible?
No. Pottery, I think, is not working. We'll change it. Meanwhile, I'll just give some compression here, so
Sir,
it'll help
Dr.
to
Praful is
mitigate the
asking,
bleeding.
sir. There is not hearing us, so.
Hmm.
And it's not.
Give it a second try now.
Yeah.
करो, 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 अच्छे से करो, थोड़ा तेज करो। बस। So now at least some things are visible here.
Yes, sir. Now the base
So we'll
is
continue with the
quite clear.
dissection curve. So the first priority is to free up all the conjunctiva. You know, this is the offending tissue.
Yes, sir.
This is what we are targeting.
So what's your approach towards the tenons? Is it to remove
Yes,
extensively
yeah.
or just to remove in that surrounding areas of the region?
Mhm. So just try to lift it up and see that, it's all free now. We have good clean margins. Now I'll go to the corneal side. Okay. नहीं, वो दे दो lamellar dissector. So I try to do most of the dissection with a lamellar dissector as it's quite blunt. And if need be, I'll use a crescent blade. उस तरफ नहीं, हमेशा हमेशा बाहर।
Professor Tushar, can you hear us?
Yes, yes, yes.
Sir,
Professor.
what's your approach toward this dissection of the bad?
Sorry?
When would you prefer a crescent
No,
and
so,
when would you prefer a blunt
so
instrument?
I used to prefer a crescent till a few years back, but I found that it sometimes creates deep unintended ridges in the cornea. So now my choice is to use a lamellar dissector, as it's the end is little blunt. Can you see that it's just separating the
Yes,
superficial
sir.
tissue without
We
any
can see it's just
damage to the
making the
underlying
bed
tissue.
smooth
So
without
if
creating
it
any
doesn't come
false
out,
fringe.
then I might use a crescent.
So do you use the diamond duster bar also?
Last in the end,
Okay.
just to finish
Polishing.
the polishing.
Okay.
So it's about, I think, 80% done. I'll just keep. So you have to be a little patient. Keep running the lamellar blade, and you will keep finding these small little planes and just chase them down. I don't know if you can appreciate on the microscope, but I can see them quite well here.
Yes, sir, it's quite clear. It's
Yeah.
visible.
And the underlying cornea is now almost clear. Either the tissue to be removed runs out or your patience runs out, whichever is first. So I think most of it is done with the yeah. So this is what I'm looking for, a smooth, clean limbus. So I don't think I need to use a crescent here. I'll just use the burr to finish up the polishing. So this is a diamond head burr, motorized burr, battery operated. So the key is that the surface should be dry for the friction, So it will be difficult to catch the movement as it's running at a slightly higher speed, but it just smoothens the bed and that's it. Don't expect it to make the dissection for you. It is just to smoothen out the bed and that's it. And we have found that it decreases the surgically I mean the astigmatism is less, final astigmatism, if you manage to polish it. There's some bit of tissue left which I like to remove now. I just spotted it. I missed it earlier, I think. Yeah. Okay. So I think I'm done with the resection. I'll just go to the graft side now. So first we'll measure the defect on the host side, on the corneal side. Pull. So it's usually about 5 to 6. In this case, it's about 6 millimeters, Praful. So
What would be your graft size, sir?
yeah, so you just I mean measure it by the eye basically. So it's going to be around 6 into about 5 millimeters or so. Then I use this Sinsky hook basically, just an improvisation, dipped in some GV paint and mark the area of the graft. Just helps because once the graft comes off, the conjunctiva comes off, it's very difficult to see the ends.
Yes, sir.
Deeper.
Once you start exercising the graft, it becomes very difficult.
So this just helps to. And once I put the dye, I generally use a sponge to remove the excess dye so that it doesn't, the lines don't spread.
Your innovations are always helpful, sir, for the surgeon. And I think this is a great step which the beginner must follow.
So now again, this is an important tip. I inject xylocaine adri below the graft area. So it causes hydrodissection type of a thing in the graft, below the graft, some hemostasis, and supplements the anesthesia. Not important in this case as much because already some block is there, but as you know, most cases are topical, which I operate mild, up to moderate level pterygiums primary. In those cases, it's really helpful to supplement the anesthesia. Now, this is a closed type of dissection. So without removing the other 3 sides, I am just running a angled vanas very close to the undersurface of the conjunctiva. So the idea is to free as much of the tenon's tissue from the conjunctiva as possible when the conjunctiva is still attached at 3 places.
This is a very vital step to
Yeah.
avoid any tenant
So you can
stand.
see that the scissors will keep becoming more and more visible. You know. So once I feel the free movement of the scissors, then I just go for the other edge. So I use all 3 1/2 scissors in these cases. So you have seen the use of curved, angled, and now the straight to cut the third edge.
Choice of instrument is very useful, very critical.
Yes, yes. I don't use conjunctival scissors almost at all in these cases. Now, so we will not bother about this bleeding which is coming. It's going to stop on its own after a while. So now this is a little tricky because my minimum surgical goal here is not to create a buttonhole in the conjunctiva. That is my first priority. And the second priority is to remove as much of tenons as I can without causing a buttonhole in the conjunctiva. So this is my order of priority. So how do I know I'm removing the tenons? You will see that the graft will keep opening up as I remove more and more tenons. So wherever I see, tenons being bunched up, I just remove small slivers of the. See, can you see the graft opening up as I
Yes,
remove
sir.
slivers of tenon? It almost goes to double size, from what you start with. Some people say that, the underlying, if you don't remove the full tenons, there will be recurrence. But I think it's opposite. It's the tenons below the pterygium which is of more priority to be removed, which is important for recurrence rather than the tenons. So I don't. So I don't want to remove it at the cost of creating a buttonhole.
Yes, sir. In fact, there is a question related to this. Is it absolutely essential to remove all the tenons? Or
Yeah, so it is. I think it is absolutely important to remove all the tenons below the pterygium itself because that's where the pathological tissue is. In this case, in the graft, I think it's more of to open the graft rather than the tenon itself. And of course, there should be no tags of tenons hanging out of the graft. I think, barring that, I think little bit of tenons. Yeah, I don't think it. So I'm quite happy with how the graft has opened up. Almost
Yes, sir.
1.5 times, and now a straight one hour. Cut it flush with the limbus as far as possible. And now don't lift the graft, just slide it across, position it limbus to limbus. Okay, so you don't lose the orientation. Now, my assistant, Dr. Neha, I think I need her help now because. So I asked the assistant, if it is in the block. So I don't ask them to use a forceps to pull the conjunctiva. I ask them to use a swab stick to the friction of the swab stick. Yeah. So that there is no tear in the conjunctiva. So drying the bed. Now the glue part. So I put it in 2 components. I don't use a diplojet. So I use the thrombin part on the sclera. So the mnemonic is, to help you remember, is ST. The thrombin goes on the sclera. And the thicker fibrin part, just a couple of drops under the graft. F and G. And then overturn the graft. Now, थोड़ा सा pull करके रखो ना. So the first thing is to oppose the edge on the limbus, which is of the most importance. Then work on the other edges, side edges, and then finally the distal edge.
So the limbal barrier is the most important part.
Yes. So even if the distal edge sometimes remains exposed, like for example, this is a very large pterygium. I don't mind, you know. थोड़ा सा यहाँ पे और glue लगेगा, एक drop दीजिए. So priority is limbal, and then the vertical edges, and then the distal edge. So that's my order of priority.
Sir, could you just, could you please bring the microscope view to the center?
Okay, okay. I'll do.
That edge is not visible to
Okay.
us. Yes, sir. Now it's fine.
Okay.
Thank you, sir.
Okay. So for all these, you know, cases, you have to make a trade-off at each step. So in your mind, you should be clear, not only in this surgery, in every surgery, you know, that every time there is a trade-off, you know, which one of the two you would rather, you know, have. So for me, the limbal edge is most important, followed by these vertical edges, and then the distal edge. So I'm just using the teeth of the limbs to just crimp the edges. This word actually came from Dr. Khoker, sir. That crimp the edges. And we are mostly done now. I'm not going to do anything more. Just one last bit of cleaning up. And this thing which I do, I take a limbs and try to see if there are any tags of glue. Sponge or DJ. If there are any, you know, tags of glue which are coming out of the graft. Very important to remove them, because I think by themselves they can cause detachment of the graft. Yeah. ठीक है, छोड़ दो. So we'll put some saline then.
There is a question in YouTube, if the diamond bar really contains diamond or the name is like that.
Praful, it costs 6,000 rupees. I don't think it contains real diamonds. You know.
Or it would have vanished from OT repeatedly.
Sorry?
If it would have contained diamond, then it would have been difficult to find it in OR.
No, must be some synthetic diamonds. No, I'm assuming, but I'm not a diamond expert. Maybe Dr. Namrata is there. Madam Namrata is there. Madam will know. Praful, we are done with the case, and
Thank you, sir. It was a wonderful surgery. I think the take-home message for the audience is how meticulous sir was in every step, like dissecting the tenons and applying glue.
thank you.
In fact, applying glue, most of us don't do that. Apply one part to the sclera, the other part to the bed of the graft,
Okay,
and
sir,
then
thank you.
oppose. It becomes so, it's such a nice surgery. Dr. Lomi, would you like to have some comments?
Yeah, obviously, my teacher, my mentor, sir. It's really nice to see you doing such a creep surgery, and very meticulously you have completed it, sir. Sir, finally, at the end, you would like to use a bandage contact lens also? Or
No, Lomi, bandage contact lens, you know, because first of all, the contact lens which we call bandage contact lens here is not a bandage contact
Yeah.
lens. It's smaller in dia.
Mhm.
So the idea is that the edge, I think, can disturb because the edge, if I can find a lens in which the edge of the lens goes beyond the graft edge, then probably okay, fine. But here I think it will be stuck on the edge, and it might be counterproductive. And there are studies which have said that, you know, it doesn't really help much. So we are bothered about the epithelial defect. We just keep a thorough follow-up of the patient till the defect heals.
And somehow the epithelial defect heals quite well.
Yeah. So it's quite sort of little strange or whatever, but the defect looks large on the table. But by I think the second by the 48-hour mark, the defects are healed. Probably because you have, you know, smoothened out the limbus and everything.
So what would be your protocol for steroids in such cases? Because it was a big pterygium and quite vascular also.
No. So I'll start steroids from tomorrow morning.
And the doses, sir, like
See,
it's mild steroid or dose?
normally I do these cases under topical anesthesia. So there the patient can open the bandage in the evening and they start the steroid drops. So when they come to OPD next day, they are quite clean and inflammation free. But in this case, because we have given a block and a slightly large pterygium, so in this case, I'll probably advise them to keep the pad bandage till tomorrow morning. We'll remove it in the OPD tomorrow and start the steroids tomorrow. Topical steroids, QID, antibiotic, fluoroquinolones, QID, and one lubricant. Lubricant I will give for 6 months.
Okay.
Steroids I will taper down in a month. Antibiotic will stop after 2 weeks, and the topical these lubricants I will continue for a month, 6 months.
And sir, what about the recurrences that you have seen in your experience with the technique?
If you remove the entire subtenon fibrosis and if you clear out the limbus, then the recurrence rate is about 4% in with this technique.
All right.
Sir,
In primary pterygium.
sir, one question. For the recurrent pterygium cases, what is your take on surgery? Like, is it different or?
Yeah, Lomi. So see in primary pterygium now there is enough body of literature that this surgery which we have just done, conjunctival autograft with glue, is the gold standard. There is no need to look for other surgeries. In recurrent pterygium, the literature and the experience is not very clear, but at the moment, my choice is if there are two types of cases you will get. One is that the primary surgery itself, the graft was not done. So in those cases, you just do a conjunctival autograft along with mitomycin C. And if a graft has already been harvested in a particular eye and still the patient has a recurrence, then I do an excision with MMC with an amniotic membrane.
Thank you, sir.
So-
Each time I watch you doing surgery, I learn few points.
Thank you, Prabhu.
Thank you for that wonderful surgery. Now we move on to our
Okay,
next
thanks.
surgery, which will be by
Thank you.
Professor Khoker, sir.
Wonderful.
He needs no introduction and he is going to teach us pediatric cataract surgery.
Right.
Good morning, sir.
Morning, Prafulla, Lomi, and who's that third one?
Sir, Dr. Rebecca.
Oh, Rebecca is not on COVID duty. All right, welcome, guys. Good morning, good afternoon, good night, depending on which part of the world you're sitting and watching this transmission. So the basic pediatric cataract is a 5-minute job going in and out. I've done few surgery down south in south in which they don't even give anesthesia. They put ketamine and diazepam, and the anesthesia guy sits next to the patient with a syringe in the hand. And I told him to put a mask and all. He says, "Sir, aap surgery kariye." So let's start with the anesthesia first. So I'm giving over to Dr. Nikhil. He's an associate professor at RP Center, one of the brilliant faculty members in anesthesia. We're very proud to have him today. Nikhil.
Good morning, Dr. Nikhil.
Hi, Akhil, sorry.
Akhil, sorry.
So, good morning, everyone. I'll just give you a quick go around of what we do before the consultant, someone like Dr. Khoker comes in. Like he said, it's basically a 2-minute job for him. But for us, every case involves some amount of preparation and the actual process. So in children, usually our standard of care is general anesthesia. I was quite surprised when Dr. Khoker said that people do it under ketamine sedation. That's a strict no-no for us. We would always want to secure the airway, especially in children. And especially since RPC is an apex center of the country, lots of complicated cases, syndromic children come to us. So we would rather not take a chance with something as chivalrous or cavalier as maybe ketamine sedation. So as you can see, this is a 3-year-old child. Male child who is basically undergoing a cataract surgery. He is otherwise ASA1, basically means that he has no comorbidity. He just had a few symptoms of an upper respiratory infection, which are now settled. So we thought we should go ahead with the surgery. We do an inhalational induction with the sevoflurane and oxygen nitrous combination. Once the child is under, we place an IV, which is an obvious necessity in all cases for us. Once the IV is in, depending on who the surgeon is, depending on how fast the surgeon is, we either give a muscle relaxant or we don't. Like in this case, we avoided a muscle relaxant because Dr. Khoker, I know, will be quite quick with the surgery. So we want to do a quick turnaround to the cases as well. Once the drugs are in, we place a supraglottic device, an ambu LMA in this case. And once everything is taped in, we ask the surgeon to go ahead. Once the surgery is done, we reverse in case the relaxant has been given and take out the LMA once the child is awake and crying. So that's it from us.
Right. Thank you, Akhil. And that's very nice and assuring to have a person like Akhil's caliber around us. Welcome. So we'll start with the EUA. Now, once the patient is under, it's not the surgery right away. We have to do an examination and anesthesia. So for all the pediatric cases, I think the first one single test which you can perform on them is a examination and anesthesia. Child is relaxed, surgeon is relaxed. There's a quiet in the room. He's not crying. So you can do all the tests properly. Okay, so we'll show you the EUA. In the meantime, she can speak about the patient from the back, and you can keep continuing watching the EUA. You can see the ultrasound excellence has been done in this patient. Keratometry was done before that on the table.
So the case that we have here is a 3.5-year-old male child who presented to the RP Center AIMS at around 2 years of age, with parents complaining of squeezing of the left eye and difficulty in identifying nearby objects since around 1 year of life. The patient was diagnosed with exotropia and with congenital cataract in both eyes, left eye more than right. We planned and went ahead with a left eye lens aspiration with a posterior curvilinear continuous capsular excess and an anterior vitrectomy with an IOL in bag under GA on 20th of March 2021. The patient was followed up at 1 day, 1 week, 3 months, and 6 months. And at 6 months follow-up, the child presented with worsening of vision in the right eye. So on clinical examination, currently the child is having a visual acuity of 6/24 in the right eye and 6/19 in the left eye on Cardiff. The extraocular movements are full, but we have a exotropia of around 10 degrees on a Hirschberg test. The cornea was clear and the anterior chamber was formed in both eyes. On examination of the lens, there was a zonular cataract in the right eye and an IOL in bag on the left eye. The retinoscopy under atropine 1% at 2/3 meters showed a -7 diopter in the right eye and +0.5 +1 in the left eye. So the diagnosis is exotropia with right eye zonular cataract and left eye pseudophakia. And today we have planned an EUA, which is currently going on. You can see the UBM followed by right eye lens aspiration with a PCCC with anterior vitrectomy and IOL in the bag under GA.
Yeah,
Thank you, Dr. Aishwarya.
Thank you, Aishwarya. Can you see the UBM now?
Yes, sir, we can see it clearly.
So you can see a typical, it's not a very hard cataract. In this case, needs a surgery because the other eye has been operated and this eye is -7. So this eye, the left eye was done in the live surgery for the DOS. At that time, this eye cataract was very mature. And now 1 year has passed, March 21, it was done. So you can see the growth in the eye, and the right eye is trying to be a little more myopic. That's good enough. I think we can switch over to the next one and clean up the patient. So since the right eye has gone up by 1 millimeter, this is the eye which is more prone for myopia. So excellence in this eye has gone up. So I'm going to undercorrect it more than the usual. In March 21, we did 5% undercorrection at the age of 2 years, which is the norm which we follow. But now, since the child is 3 years, we'll still go 5%. That means doing little over undercorrection. That means we'll leave him a little more hyperopic. If you see the retinoscopy, the other eye, it's about 0.5 and a +2. That means it's almost emmetropic or shifting towards the myopia side. So we don't want him to go into further more myopia. So we'll tend to control it in this side from the word go right away, right? And if you even have a difference of +-2 diopter in both eyes, there's not a problem because you can never be very sure which eye is going to grow, and nobody has any standard rule or scale to measure that. So now we're cleaning the patient and we'll start the surgery immediately. Any one question we have before we start, I can take it up. And
sir, what was your target for the first eye? Target refraction?
Okay, so target refraction was 5% undercorrection at 2 years. So whatever power you get, you go 5% undercorrection, you expect eye to grow. The normal formula which they follow, all these, I think Edward Wilson, all these formulas from Caucasian eyes say that in the first 6 months, the eye grow by 0.6 millimeter every month. So 0.6 into 3 becomes 3.6 millimeter from 0 to 6 months. After that, the growth is less. But in this patient, it's surprisingly last 1 year, the eye has grown. There could be two reasons. One, the cataract has become a little more mature and blocking the eye. Although when you see the eye, it's quite a clear, almost a clear lens. But since it's blocking and causing peripheral blur, which induces myopia. But the other thing is excellence has also changed. So that means this patient is little prone for myopia. So this is not a routine run of the patient, patient, but yes, you have to take extra precautions. So 5% at the age of 2 years. And at the age of 5 years, you do a 2% undercorrection, and after that, you could be emmetropic. Okay, so we switch over to the surgery now. My aim is not to finish the surgery quickly, but I want to show you the steps, which I think all of you people are doing very well, but some of you people struggle. So this is meant for the people who want to learn and who are still struggling. And the guys who already are doing a great job, they can go out and have a cup of coffee. I think it's running regular outside the auditorium. Throw tight for those. 3/4 of the circle. Yeah, that's good. All right, so there we go. Can you see the microscope view now?
Yes, sir, we can see it.
All right. So here we go. So that's what the eye looks like. Now you tell me, if this eye comes to me with a bilateral cataract like this, and the vision is, zoom in, can you, right? Okay. All right. 1 second, give me a minute. I'll just get it focused. So you can see 3 spots on the light.
Yes, sir.
Yeah, so that is not a retro. All the lights are on. So once I do this, you get a retro, which is 2 lights on. And if you notice here, there's one ring in the center and there's one other ring at the mid periphery. So that means the peripheral blur could be because of that. All right. Pupil is good, well dilated. Pediatric cataract surgery is always a 3-incision surgery. I mean, there's no point in making only 2 and struggling. So 1 in, I use my left hand because I'm a right-hand surgeon. So non-dominant hand first incision, then comes the second hand opposite side. Okay. And then the third one. Can the sound of this can be reduced a bit, please? So you see my main incision, I'm enlarging it a bit with the blade because I'll tell you what are the advantages. When I use my long forceps to make the rexes, the knuckle of the forceps is not going to get stuck. So my standard format here is air, edry, and dye. That's a cocktail we use for all the kids. So little air, then putting the edry will go under the air at the edges and dilate the pupil. You see the pupil opening up?
Yes.
I'm using the dye just to tell you guys, for the beginners, if you have a white cataract, use dye. The fluid is going down on my feet. You put the bag, put a pad here. Take drape of the please. Okay, so I leave the dye for a little longer as compared to the adult eyes, and I'll take it out from all the openings, first, second, and third opening. So by doing so, what I'm doing, I'm trying to clearly define my incisions. You can see all the incisions are stained now. So since they're stained, when you go in, you're not going to be, rubbing against the epithelium and the endothelium. So now I'm using a Helon GV. It's a high molecular weight. Anything more than 4 million Dalton should do the trick. I could have done the rexes without dye, but for the audience sake, I want to tell you that always use a dye so that entire capsule nature changes. So we did a little study in which found that the central zonular cataract size is usually between 4.5 to 5.5. So if you don't have this ring, can you see the ring now? Prafulla?
Yes, sir, we can see the ring.
Okay, that's a 5 millimeter ring. It's basically to make sure that the lens is covered on later on the IOL. So there we go. Go in the center, give a nick, and don't be a Superman. You can't finish it. So just give a nick and leave it alone. Now what I done is I did a nick from the side, so my nick is horizontal. So I come from the main incision, and voila, the wound is ready, incision is ready for me to pick up. So I hold it, go all around, and if you the adults, you hold it for 4-5 times, here you use for 5-6 times, and you're gonna get a good round rexes, and every time. Okay, every time you go close to the leading incision, go back and go around. All right, here you go.
So your aim is to stay within that 5 mm ring.
Exactly, exactly. So even if you go a millimeter on each side, either side, if you're in a beginner, it's not going to make a difference. But if you don't want a VOs, it's best to have. So that looks like a 5 millimeter, little ovalish, but that's okay. So now I'm going to do a little rotation of the nucleus. You can see it's so easy. Now that's the easiest bit of the entire surgery. It's like a putty, like a custard pie there. You just put a spoon and eat it up. Is it clear or should I zoom in for you guys? I think it should be good with you guys.
No, sir, it's visible.
Okay, fine, perfect. So I use my MST bimanuals, no financial interest, but this is the one which works best with me, not with me, but with my incisions. So I use a 1.2 keratome blade, so it gives me a good support. See, there's no leak of the fluid, the chamber is deep. I'm going to eat this nucleus. All right. I had other patient planned with anterior capsule plaque, but since the time is given for one, I'll just show you one. Rest one, I'll put it on the YouTube for the guys to see later on whenever they have at their own convenience. Okay. So see, I didn't hydrate the way under the rexus margin. and everything is coming up like proteins. You pull one edge and coming out. It's something like visco-cohesive, viscoelastic is how the lamellas are behaving right now. But once they get denatured, like a boiled egg, then they start behaving like a eyes patient moving a bit, please, guys. Okay. मेरे को बता देना कुछ नहीं. It's little light. Okay. Yeah. No. On a routine day, this would have been over by now. I'm sure Dr. Akhil knows the timing. But since I want to show you all the things, there's no point in rushing and finishing the surgery if the guys want to see. Okay, so what I'm doing is polish the posterior capsule, please. I'm struggling a bit, but that's okay. I know what I'm doing, so that's okay. I'm sure within a few seconds, this will get centralized. Sorry for that. Okay, there you go. So now what we're doing is we're going to put Helon again. We got a biometry done in this patient, but we are doing a study in which we're doing on the table system to make sure the bubbles don't come in the piece, viscoelastic piece, not in Helon, please. So the Rexus looks good. I'm going to check power of the lens now with Aura BSS. Make sure there's no bubble in that. You can open other one otherwise. So to do the Aura, I have to make sure the 4 mm is clear and no bubbles there, and surface is cleared up. So that's what we're going to do. Okay, the Aura, please. I can't see the screen. Okay, so Aura shows you that this is what a machine, it's an OptiWave refractive. So it's picking up a lower order abrasions, that is spheres and cylinders. Yeah, please capture. So I'm going to bring that light inside, and it takes 40 images in a fraction of seconds and gives you a refractive error. So let's see what it tells us. Okay, so it tells us that if you go 14, you're going to be 0.68 plus. And that's what is the plan. And that's what has come on our sheet of the IL master as well. All right, so once this is done, you can't leave the posterior capsule intact because it is going to become absolutely opaque within few days. So don't take any chances. Take off the posterior capsule. So posterior capsule, you have to remove the viscoelastic from the chamber now so that you don't have posterior capsule pushed backwards. All right, so I'm pressing the main incision. You see the noodles coming out like visco-cohesive. We had a very good class by Aishwarya a few days back. I'm sure all of you must have attended that. Okay, so there I go from the main incision now. Come on. All right, so how do you open the posterior capsule? You just dig in 1.5 millimeters from the center. Just roll your blade across. Dig in and roll it. And you got a cut. You see that?
Yes.
Rather than digging it in, if you go put your needle backwards, you tend to disturb the vitreous. So what I roll it over. Okay. Second trick is to put a soft lens on the eye, which is in the form of viscoelastic. There's a little overfilled chamber. That's why the posterior capsule is too posterior. But nonetheless, we'll manage this, don't worry. So it's too posterior actually. Okay, so hold it at the edge, lift it up. Okay, it's broken off from one side, no problem. Okay, now this is a bad combination because overfilled eye with a myopia is not a very good combination. It's really gone too posterior actually. So I'm cutting it again and trying to hold it and do it again. Now it's breaking off because there's more viscoelastic. I have to remove the viscoelastic from the eye. So what the trick is to go inside, press the posterior lip and press the posterior lip. All right, it's all in the bag now. No problems. Okay. Forceps again. Okay, so what you see is it's not a very good looking Rexus right now. But the trick is that we're not over yet. All right, so let's find out where's the weak spot now. So you can get into a catch-20 situation. If you notice, my posterior capsule is so posterior that every time I have to dig in, I have to really dig in hard. And once I get a grip, I am pulling it up. Sometimes these new forceps are too sharp at the edges. So they hold the tissue and they break it off. So what I'm doing is I'm just holding it gently, very, very gently. It's something like when you're doing a putting on a golf green, the way you hold a putt. I mean, you don't have to put any pressure. It has to roll naturally. So just hold it, okay, and go. So has it joined? Not sure yet. You see, there's still a loose end. I'm so happy it didn't happen in one go because otherwise there's nothing to learn. So now see, I've got the grip. Don't leave it till you're convinced that, okay, now we got a,
Right.
good, it's all complete. So this should be a message that don't overfill the capsule. This is what happens if you overfill the bag. You can fill in the anterior chamber, but not the bag, please. So now I'm doing a vitrectomy in this patient. Now see with the fluid also, the chamber is going so deep, which is telling us that the fluid also, vitreous is also fluid. Okay. How much time is left for us? I'm removing the bubble for your sake so that you can see better. Come on, come on, come on. 15 minutes, eh?
Yes, sir. We have 15
Oh,
minutes.
we got enough, yeah. So we can show off a little bit more then. I mean, show, no off. Touched upon it. So what I'm doing is I'm going under the anterior posterior capsule. See, my probe is going facing downwards. I'm lifting the capsule off. So I'm cutting all the hyaloid. In doing so, I'm taking away all the scaffolds and whatever support is there so that we don't have a VO formation. And since we have time at the end, I'll just show you the picture of the other eye, which was done last year. And which eye will grow, which will not grow, you can't predict those ones. But yes, the patients who don't use their glasses and who don't use occlusion will grow definitely.
So what is your end point of vitrectomy?
Perfect. So you see the shape which I created, is the shape is maintained one. There's no edge which is vitreous coming anterior and making it pull towards one side. And the margins get curled up. I'll just show you what I mean. So I've got vitrectomy all around. Okay. So remember the shape I made?
Yes.
It's the same. So if there was a vitreous, would have been getting, crook towards one of the sides, especially towards the incision side. So that's where you should see 1, 2, and 3 area. So all 5. All right. So we're good.
So what's your take on the use of a vitrector for making a posterior PCC, for doing a posterior?
Whenever you cut without rexes, you can get an opening, which will get fibrosed over a few months, but on the table, they'll be weak. They all will be weak. So when you put a lens and you apply some pressure, it's going to be bad. So what I'm going to do now is I'm going to look into the retina, because when the patient comes at 1 month, 2 months, 3 months, nobody has seen the retina till now. So what we started in RP center is each eye, the retina is evaluated. And what I'm doing is I'm putting wide angle with the ELO on the side. And I'm happy that Professor Tityal has given us all the liberty to buy all these equipments. And what you see now is, you can see the tigroid fundus. I'll zoom in, I'll zoom in. We got 15 minutes, so there's no problem at all. So you can actually document and take pictures. And we published this work in BMJ about a couple of years back, appreciated by all. And all my Westerner colleagues have started using UBMs and wide angles on the table. All right, so the margin is blurry. You can see the peripapillary atrophy all around. So this is an eye which is a myopic eye. You can see that. Can you guys appreciate that?
We can see that.
I'll focus it now. It's better. All right. And we come out, and that's about it. The next step is we got a donut there, anterior capsule, posterior capsule gone. So you just have to put in a lens inside. And these microscopes are so good that you can actually play around with them. You can go to 2 light source, 3 light source, and retro mode. They're wonderful. And for the kids, I think you should not have any shortcuts, because they have to live about 80, 90 years. Okay? Any adult patient at the age of 80, 90, give or take, will have 20, 30 years, right? If they cross 100. Okay. Here we go. So what I'm doing now is I'm making the bag now. So Rebecca, coming back to your question, if I'm done with a cutter, at this stage, when I put a Henon inside the bag, posterior capsule will become bigger. It might just run off in any of the directions.
Okay, because of the irregular edges.
Yeah, because of the weak edges. It might look round, but they can never be round. When you cut off like punch by punch. All right, so you can see that now the trick of putting the lens is do not use a wound assisted system in this one. You'll always miserably fail. The lens might go into vitreous. So what I'm going to do is I'm going to make a 2.8 system. Yeah. So I don't use 2.2, I use 2.8. So in and out. So what happens is your cartridge tip goes all the way in, and your lens is put into the bag. Now this is a technique again we published about 10 years back. I think everybody's using it. Now you see the lens going in. I go in the bag, I just I just push myself into the corner there, into the bag, and I push my lens downwards so that I hit against the posterior surface of the anterior capsule. Let me repeat that. It goes under the posterior surface of the anterior capsule. So if your posterior capsule is not intact, you can still manage it. Now, the leading one can be tucked in very easily. See how easy it is. And that's what it looks like. So you have a lens, you have anterior axis which is covering well, which is pretty good. And the posterior axis is always round. You can't leave this patient without suture. That'll be a criminal offense if you do that, because the chamber might become shallow. The child will cry, he'll rub the eyes. So you have to have a suture on the main port. Incidentally, when I did surgeries in Australia, they made me suture the side port also. So when I came back, I thought we'll devise a technique in which we don't have to suture the side port. So bubble stabilization in the chamber, Dr. Tushar helped me on that. We came out with a technique. I'll be showing you that also. These are very small things which are common sense, but once, as people say, the common sense is the least common thing around. So always make sure your sutures are good. This kid is about 3 years, so not a big deal, but still you need to have it. The kid about 1 year, 2 year, 3 year, 1 month, 2 months, 3 months, the suturing have to be good. So I'll show you the technique, but even if you feel your chamber is not stable, after that, you can please go ahead and put sutures in all these patients. Be safe rather than be sorry. So suture buried. Pediatric sutures have to be buried. It's not over till the suture has been buried inside. If you're leaving it alone for later and you forget it, I think you're going to get in trouble. The child will not open the eye the other day. Okay, so now I'm going in with the eye cut. Again, the chamber is a little deeper because it's a myopia. You see that? Being pushed back, you can hardly see the iris. See, about 30 years back, the machines were not good. All these systems were not perfect. The chambers were not very well maintained. I remember the iris coming, people getting chafing. I learned so many things from my seniors. And there's so many things we learned, that what not to do and what to do. So it goes both ways, actually. I'm sure the younger generation, when they come, they'll also improve the techniques we made, and maybe they'll do much better than us. I'm sure about that. So all the helon is gone. Initially, we were scared of going under the lens, but now with both the rexes intact. And the second thing, if you have a posterior rexus not continuous, Rebecca, you can't go in the bag.
Right.
And your fluid has to be controlled, because any pressure in the bag will open up, it'll rip it apart. It'll rip it to the, and then you have to change the lens from single to a 3-piece lens.
Oh.
Right?
Right.
I'm sure you're satisfied with the answer now. You want to add on something? If you have something in your mind, please go ahead.
No, sir. Thank you.
So whenever somebody asks a question, he already has an answer. So I want to know, what was your answer? I mean, if you want to share it. So that's a bubble in the center. Give me a minute now. Okay. So I'm going to hydrate the side ports now. So I'm going here and hydrating. All right. So is the bubble expanding? Bubble will expand if there's leakage of fluid from any of the ports. So it's not expanding, right? But the bubble size is big. I want this bubble to get absorbed by tomorrow. So I'm going to.
Sir, do you use triamcinolone acetonide routinely in your cases?
No, I don't. Because with the good microscopes and good rexes and the shape of the rexes, you can see well. Yes, but it's not a crime to use it. The only thing is the pressures might shoot up in the next couple of days. So I think it's better. You can use it if you're a beginner, but in most of my patients, we don't use it. If you ask me in my practice, maybe one case in a year or so it's required. Otherwise, I think most of the kids are doing pretty good.
Yeah, Sudarshan, good morning. Terrific surgery.
Oh, morning, sir. कैसे हैं?
बहुत बढ़िया.
आपने कल पार्टी के बाद मेरे को यहाँ बिठा दिया आज सुबह सुबह.
नहीं, ये भी पार्टी हो रही है. The way your surgery is looking is.
No, I ran off. You haven't seen me party yet. Then that wasn't a party for me. Anyway, next time. So we just got 2-3 minutes. So this is how it looks like at the end, and the surgery is done. The bubble is stable, and the kid should do well. Okay. And I'm going to give a subconjunctival injection which has a steroid and atropine routinely I put. And next morning or maybe in the evening, the child, you can do a refraction and it's not going to change much. I'll just show you the other eye, which was also done in live surgery, DOS. Dr. Titiala was telling them this kid is live surgery kid. So I picked it up because the other eye has shown some changes. So I just want to tell people that you have to follow your patient. Cornea flash karo, please. So you have to follow your patient and realize what you do. Now you see the rexus posterior is round. It's 1 year. Anterior capsule will always fibrose a little bit. So you see the rexus size same, posterior is round in all the cases, even all my SR. I think everybody get a round posterior rexus. The myth that the posterior rexus is difficult is not good. You see the lens now, It's perfect, and 1 year gone. See, the maximum amount of VOs which they have to form, they form within 1 year to 18 months. So he's already crossed the period. So I think he's going to do well. And if you follow the technique of going behind the capsule with the cutter downwards and take away the scaffold, it's going to work well. So any questions if you have?
You're looking great with a customized cap,
Yeah, it's for the pediatrics. The kids gave me, so I thought I should use it. And I thank again to Akhil because his support is always there. I'll just come in the front there.
Sir, there is a question about, is it absolutely essential to remove all the hilon after the ion is put, or can we leave little bit of it behind the ion?
Okay, if your hilon is a good quality product, then you can leave little. You can't take out everything. You can't go to the periphery and remove everything. Whatever is in the chamber will come. You can rock and roll. You can push the lens down and do it, but you don't want the haptics to come out. So I think it's okay if you leave a little bit. It's always left behind. It never comes out in toto.
Any role of PI in pediatric cataract?
Okay, so if your lens is not in the bag, that's where the PI comes in, and especially if you're not doing a vitrectomy. So there was a study in which they were doing the capture of the lenses and not doing vitrectomy, just doing the PCC. In those patients, you can. And if your sutures are not making the chamber deep, if your chamber is not well formed, you should do a PI. And if you're handling a patient with the anterior segment dysgenesis or iridofungal coloboma or microphthalmus, in those patients, routinely we do PIs. But these normal size eyes, it doesn't make a difference. And we're living this for last 20, 25 years now, and no problems as such.
Yeah, Sudarshan, you've chosen a, hydrophobic foldable lens in the back.
Right.
Is there any consideration of choosing a aspheric versus spherical lens in the pediatric patient?
Okay, I think if your centration is good, aspheric works wonderfully well. And the advantage of aspheric is even if you're a little off center, it's not going to make a difference. So we prefer using aspheric, but there's always a study about aspheric and spherical. But most of the centers have switched over to aspheric lenses now. They're not using sphericals at all. But then if you're using a 3-piece lens, there could be a little problem. If you have a problem and you're doing a capture, it might not be centered. In 3-piece lenses, you can use a spherical lens in case you want to play it safe.
Good morning, sir. Ankur here.
Ankur from Jaipur. Yep.
Yes, sir.
Yeah, please.
Sir, happy to see that we are seeing fundus for all these patients.
Yes, we do.
But is it not necessary to do the gonioscopy also? Because at times we have glaucoma in these patients amounting to up to 30% of these patients.
Of course, we do gonioscopy routinely in patients who are mesodermal dysgenesis or been referred by Tanuj or Dr. Ramanji. In those patients, we do, and we have a all set up. But I didn't want to show it here because I don't want everybody jumping and doing all these investigations on the table and losing J time. But yes, all the patients we are indicated, Ankur, we always do a gonioscopy. Yes. We do the corneal thickness in those one, we do IOP on the table, and we always do that. Yeah, good.
Thank you, sir.
Good morning, sir. This is Devang. Sir,
Yeah.
it is always an eye soother to look to watch your surgeries. So you had mentioned that you use triamcinolone in one patient once a year, maybe. So what is your indication of using triamcinolone?
Okay, so if somebody else is operating the patient, he calls me that he's not sure, and I don't want to manipulate and the anesthesia is not too deep, then those patients I put in because it makes my life easier. It makes me the strand see it coming out and you can chop it off. Yeah.
So not in your primary surgeries.
It's not, okay, like there are different group of people who say that you should use it in all the patient, but if you see the pressure rises in 33% of patients, the pressure is going to shoot up. So I think if you've got microscopes which are good and you can see everything and your axis shape is maintained, so that means there's no vitreous in the anterior chamber. Your aim is...
Says that tip is very important, that tip of please watch the rexis margin.
Yeah.
If you see some triangular or some shape is there, then you are sure. So I don't think it should be a routine practice.
No, it should not be a practice. It should not be a routine practice.
As such, pediatric guys can land up in glaucoma, and we are just
absolutely right.
Adding one more risk factor to that.
Exactly. And the problem is in the small setups where the microscopes are not good.
Yes.
Then you get in trouble. If your microscopes are good, your visibility is good, you don't need all these things. You get in trouble when you're not clear what you're getting. You're not getting good retro. You don't know how much vitreous is coming into the wound. In those cases, if you put the lens won't be centered because the vitreous stand is going to make your life miserable. And over a period, it'll contract and you push the lens off the center. So in those patients, yes. Otherwise, no.
I remember one study, from Jagatram.
Yeah.
He published in these pediatric cases, doing vitrectomy done in all cases. And he thought everything's clear, and they reviewed all these cases. Next day, they saw around 30% of the cases, the vitreous tracts were still there.
Yeah.
So then he started recommending you should, after doing a complete implantation, you feel everything all right, just put a transfloor in anterior chamber, see if their tags are there. So that was his recommendation, and Sudarshan is absolutely correct. If you can see well, there won't be things. But yes, if you have a small pupil, hazy things, not seeing clearly, I think that's one way of avoiding vitreous tags in the side ports, especially side ports.
Especially when you put the lens in these eyes, if the lens is going smoothly and you can see the rings of the same shape, there's nothing amiss. You're good. And the bubble, when in the center, the bubble is mobile freely, there's no vitreous in the chamber. Again, it's good. The pupil is round. So as Professor Tityal saying, if you can see it, I mean, then you don't have to do any funny things inside. Otherwise, yes, for the beginners and for the people in your trouble, you can use Triamcinolone. There's no restriction, but keep an eye on the pressure for the post-op period.
So that's when you have such a long, because the follow-up of these patients, you have a larger series of pediatric cataracts. We did doing, routinely a PCC vitrectomy in the younger children. Is there any, significant increase in the posterior segment cystoid macular edema in pediatric patients, or they don't have at all in the pediatric cases?
See, that
because
way,
adults we talk about, CME in all cases.
Yeah. See, the pediatric patients are blessed in the way that because the vitreous is well formed. I think there was in one of the videos, there was an article which says the vitreous of the child is blessed because if you do the anterior vitrectomy, the posterior vitreous does not move that much. And you're not putting too much fluid and you're not doing a deep vitrectomy. You're doing just a core anterior vitrectomy and you're taking the scaffold away. So it doesn't have that much. Only once, I think the study says about 1% CME. I remember most of the studies don't have any of these CME. So that way, I think the kids are blessed.
Thank you, sir. Thank you for choosing this case, sir.
Yeah, I wanted to teach, so I think I've done the job. So thank you very much, and thank you all the staff to come on a Sunday to help me out, please. Thank you.
Thank you, sir. So we move on to our next surgery, which will be a strabismus surgery, and I would like to.
Dr. Tanuj there. No? Tanuj is not going to do a strabismus.
We have the glaucoma session now, and we invite Dr. Ankur Sinha, Dr. Shikha Gupta, Dr. Devang Ango to take over as this for the next session.
Good morning. After a beautiful surgery by Khokar sir, we are now moving to the next session where we'll be demonstrating glaucoma surgeries. The next surgery is by Professor Tanuj. He'll be doing goniectomy with a phacoemulsification.
Good morning, everyone. Here we have a 72-year-old female who presented to
EB team, could you please increase the volume, please?
Good morning, everyone. Here we have a 72-year-old female who presented to us with the chief complaint of diminution of vision in both eyes for 3 years, gradual, painless and progressive. She had no other forms of medication taken, no family history of glaucoma, and systemic examination was within normal limits. Her uncorrected visual acuity in both eyes was 618 and best corrected visual acuity of 612 in both eyes. Her IOP on Goldman applanation was 20 mmHg on travoprost in right eye and 14 mmHg on travoprost. Anterior chamber was von Herrich's grade 3 to 4. And on gonioscopic examination, both her angles were open with the ciliary body band visible. Lens status was immature senile cataract, nuclear sclerosis grade 2 with mild PSC, and Cubdis ratio of 0.9 in right eye and 0.8 in the left eye. Here we can see both the angles were open. The visual field examination showing inferior nasal step corresponding to the superior NRR thinning. Diagnosis, both eye POAG with immature senile cataract, nuclear sclerosis grade 2 with PSC, planned for right eye phaco plus PCIOL plus bent ab interno needle goniectomy under local anesthesia.
Can we start?
Yes, sir. Good morning, sir.
So, Praful, you gave me a shock that I have to do squint surgery. Huh? So, good morning, everyone. So, this is a new technique, minimally invasive glaucoma surgery, where we are not touching the conjunctiva, so that is available for any future glaucoma surgery like tabexectomy or tube. So ab interno is a minimally invasive glaucoma surgery. here we have to operate on the tubercular meshwork, because in primary open angle glaucoma, the main cause of resistance is in the tubercular meshwork. So the basic principle is to remove a part of the tubercular meshwork so that the aqueous has a direct access to the canal of Schlemm, and through that to the episcleral veins. So this is a surgery which is advocated for early to moderate glaucoma in patients who have got an open angle and are undergoing coexistent cataract surgery. There are two ways to do it. Either you complete the phaco and put the IOL and then do the surgery. But what the technique we are following is to do a pre-phaco goniectomy, because that gives a better corneal clarity, and if there is any hyphema, then that clears during surgery. Now, the new skill required for these surgeries is intraoperative gonioscopy, and that is what I'm going to demonstrate. So the first principle for this is you have to see the anterior chamber angle through the microscope. So for that you require two special maneuver. The first is that you have to tilt the microscope. So I'm going to tilt the microscope because you have to focus on the anterior chamber angle. And after you tilt the microscope, the second tilt is that you tilt the patient's head. So since we are operating from the temporal side on the nasal angle, so we are shifting the patient. So there are two inclinations. One is of the microscope and the second one is of the patient. And the first step is to see the anterior chamber angle. So now you can see the cornea is focused. Give me the gonioscope. So this is the Swan-Jacob intraoperative gonioscope. So this is what is used for any surgery on the tubercular meshwork. So basically what you have seen is gonioscopy in the OPD, but now you have to learn how to do intraoperative gonioscopy. So you indent the eye and then you put in the gonioscope, and now I'll be focusing, and you can see now. Are you able to visualize the anterior chamber angle?
Yes, sir.
Is it focused? So you can see the iris, and above that you can see there is a fine white line, that is a serial spur, and above that is the pigmented tubercular meshwork. So basically in this surgery we are using a 26 gauge needle to incise this tubercular meshwork. So this is called bent needle ab interno goniectomy. So now you can see the angle is visualized, and so it is an open angle in which we can operate.
So you don't prefer to use pilocarpine before starting the surgery? Sir?
Yes, please.
So do you prefer to use pilocarpine before you start doing the angle surgery?
So I think pilocarpine we can use if we are doing it after phaco, because then you can configure, but pre-phaco we don't want to use pilocarpine because then it may interfere with phaco.
So any choice of viscoelastic, sir?
So here you can use any cohesive viscoelastic, but I prefer to use Helon or Helon GV. But any cohesive viscoelastic you can use, and methyl cellulose for the cornea. Give me the 2.2.
So is it necessary to start with the 2.2 entry if you're doing?
So now we're just injecting viscoelastic to deepen the anterior chamber.
So can we do with the side port only the angle surgery and then
Yes,
proceed
yes,
with the
we can do that. Give the 26 gauge needle. So give me a plain needle and give me so this is the now normally the minimally invasive glaucoma surgery. Why it is not so popular? Because it's very expensive, and you have like stents available for the canal of Schlemm which are costing $1,000–2,000 US, and you have Kahoot Dio blade which costs 35 to 40,000. So this is a low cost maneuver. So you just need a 26 gauge needle and you slightly bend the 26 gauge needle. So this tip is going to incise the canal of Schlemm. So this is the simple instrument you require, very low cost technique, which is useful for developing countries. And there is no point in buying any expensive instruments for minimally invasive glaucoma surgery. You will be handling give me the. So here you require a very good assistance because you have to do intraoperative gonioscopy, and at the same time you have to maneuver through the canal of Schlemm. So now we are going to enter the anterior chamber.
So how do you safeguard the anterior capsule from the needle during this surgery?
So this is, you have already put in viscoelastic. So it's a deep chamber and you require some level of expertise for this. So I'm just going to visualize the angle. And now you can see a part of the angle is visible. So we have to deepen the anterior chamber angle. Give me a side port.
So bending the needle in the other direction would allow us to push some viscoelastic also with the needle if there's a bleed.
This is a cannula. Which one?
Yes.
Needle. Can visual give me a limbs? They clean the gonioscope. So now you see it's very important to clean the gonioscope because visualization is difficult for intraoperative gonioscopy. Just take off the air bubble. So now you can see this is the trabecular meshwork visible.
Yes, sir, it's visible.
So basically first you have to, and you're applying pressure on the gonioscope. So now we have entered the trabecular meshwork. Is it visible?
Yes, sir.
Yes, sir.
And then gradually you're going to peel off the trabecular meshwork. So now we are within the trabecular meshwork. Just take off the blood from the cornea. So now you see I had entered the trabecular meshwork and then I have started peeling off the trabecular meshwork. That is called goniectomy. The challenge is that because this is intraoperative gonioscopy, you have to maneuver and at the same time do the surgery. So as you can see, there is difficulty in visualization. So this requires a lot of expertise before you can maneuver. So now you can see this part, you can see this white zone appearing here. Watch carefully. So this is the area where the trabecular meshwork is being incised. So gradually you incise and you can incise. You can see now I'm going within the trabecular meshwork and incising this part of the trabecular meshwork. You are putting pressure on the gonioscope. So this is the area in which goniectomy is being done, and I'll just peel off the trabecular meshwork. Now give me viscoelastic. This heel on. Yeah, put gonioscope. Now you see carefully, this is the area in which the trabecular meshwork is visible. And I'm applying heel on, and you can see in this area, the trabecular meshwork has been peeled off. So basically, you have to do between 30 to 60 degree of peeling of the canal of Schlemm. So now the canal of Schlemm has been exposed. You can see this white zone in this quadrant, and in the adjacent quadrant, you can see the tubercular meshwork is still visible. So this is what is known as ab internogoniectomy. In an area of 40 to 50 degrees, we have peeled off the tubercular meshwork, and now we are just going to inject some viscoelastic on the adjacent side. So clearly you can see this area of the tubercular meshwork has been removed and the Schlemm's canal is exposed. Now the major complication that you can occur you can have is intraoperative bleeding, but how we have not been having that, because we have used Helon viscoelastic to tamponade this, and that is the advantage of doing this surgery pre-phaco, because if you do it after phaco and you remove the IA handpiece, then you can have a hyphema. So I'll just show you one more view of the gonioscope. Give me the put in the gonioscope. So now you can very nicely see this area in the center where the tubercular meshwork is removed, and you can see adjacent area where the tubercular meshwork is visible. So removing 30 to 60 degree of the tubercular meshwork is adequate for lowering the intraocular pressure. You don't need to do 360-degree surgery on the tubercular meshwork. And after the surgery is done, now take off the gonioscope, just clean the eye. And so now you can proceed with your regular phacoemulsification. So this is the procedure of bent needle ab internogoniectomy. And I showed you this surgery pre-phaco. The other option is, like Dr. Shikha was explaining, that you can complete the phaco surgery and after putting the IOL, you can do the surgery. But the only issue is sometimes you get corneal edema and the canal of Schlemm is not clearly visible. And the second issue is that at the end of the surgery, you can get a hyphema, and that is a important post-op complication. Patient can have a reduction in visual acuity. So if there are any questions, I'll be happy to take any questions on the ab interno surgery.
So sometimes when I think that there could be corneal edema in a case with hard cataract, what I do is I stain the capsule first and then put Helon so that I don't have to remove the Helon and then stain the capsule before starting the phaco. So, and trypan blue, when we insert just before doing the angle surgery, it also helps in delineating the Schlemm's canal as it becomes blue in color, especially in those eyes where it may not be so visible. So it helps in demarcating the Schlemm's canal.
Yes, that is definitely a very good suggestion. We can use staining preoperatively, especially if there is a dense cataract. And in this case, the tubercular meshwork was very nicely pigmented, visible, but sometimes it is lightly pigmented, and there it is very helpful to stain with trypan blue dye.
The other advantage to perform goniectomy after the phaco is in angle closure eyes, where the angle automatically opens up after doing the phacoemulsification. So this procedure is easily doable even in angle closure eyes after phacoemulsification, after putting the pilocarpine.
Yes, Shikha, actually we have been doing an angle closure, and there what we do is we do the phaco, put the IOL, and then first we do goniosanicolysis. We lyse the region of the iris with tubercular meshwork, and then do this procedure. So definitely in angle closure, it is to be done after phacoemulsification when the angle is mechanically open.
So more than 50% of the angle closure eyes actually don't even require goniosanicolysis. The angle just opens up.
Yeah, so that you can visualize on the table after surgery. You do the gonioscope and then see if there is any adhesions, then you can take off the adhesions, because basically you are only operating on the nasal side. So if that has adhesions, you can take it off. If there are no adhesions, then of course you can proceed with directly with the goniectomy.
And so I also prefer to enter with the side port only rather than entering from the main port with either the MV or the needle that we are using. It helps in maintaining the chamber in a better way during the surgery. That's my...
Yes, so I think that is definitely possible. You can even use an anterior chamber maintainer, but if you have a good cohesive viscoelastic, then I think in one go you can do this procedure.
Yes,
Another important thing is that you must counsel the patient for a propped up position and to avoid any Valsalva maneuver, and especially any strenuous weightlifting or head down yoga postures, because any of these ab interno procedures can precipitate a hyphema in the post-operative period. So that is something you can counsel the patient. And the second very important thing is that these are surgeries only for early to moderate glaucoma. The intraocular pressure lowering is between 10 to 20%. So patient, you may just reduce one drop with this surgery and the IOP may be lower, but you may not achieve target IOP. So that you must counsel the patient that this is a interim surgery. It can lower the IOP, but if the glaucoma progresses and if there is a need, patient may require a subsequent superior trabeculectomy. And that is the advantage of this procedure, that you have not interfered in the area of trabeculectomy, and that is the advantage of the ab interno procedures.
And Ankur, yes, I just wanted to add, sir, I've just done a couple of them, but what I feel, it's more of a visual surgery rather than a feel, because you don't feel anything when you are entering trabecular meshwork or cutting it up. The moment you start feeling something, you probably are more deeper into it.
Yes, I think that is very important, because firstly, you have to learn how to do intraoperative gonioscopy, and then you have a tactile feeling of incising the trabecular meshwork, and then you start operating. And another option is to use a intravitreal forceps that has also been tried instead of the 26-gauge needle to peel off the trabecular meshwork. But that is expensive, and that is why I didn't show that, because this is surgery which can be easily adopted by any anterior segment surgeon for early to moderate glaucoma, but that is another option.
Yes.
So how much angle do you treat in pediatric glaucomas? More than this, or 30, 40 degrees should be okay?
So I think, Shika, that has really not been evaluated, and currently we only have data for the 360-degree trabeculotomy, and some surgeons have also started doing the GAT procedure with the 5-6-proline ab interno. But I think that for a congenital malformation of the angle, it is better to do the conventional trabeculotomy or a suture or a catheter trabeculotomy, because this procedure you are only operating on a limited part of the canal, and if there is a trabecular degenesis or anterior segment degenesis, then the success rate will be quite less, and you don't want, because these are examinations, surgeries under anesthesia, so you don't want the patient to be subjected to multiple anesthesias. So I think currently I won't advocate bang for congenital glaucoma, but definitely for early to moderate primary open angle glaucoma.
Thank you, sir, for
Sir,
showcasing
could
the
it be
bangs.
done? Could it be done after a trap, sir? Like if the trap is not working in a patient?
So Ankur,
Fail
actually
traps.
the issue is that if the patient has got an advanced optic neuropathy and you have a very low target IOP required, so if the trap has failed, then this surgery will not be adequate for lowering the IOP. And secondly, the long-term outcome we don't know, because see, you are operating on a very vascular structure, and there is bound to be wound healing and subsequent fibrosis. So the long-term outcome is not known. So I would not advocate in a failed trap. It is better to do a revision trap or do a trap at a other location rather than doing a ab interno surgery, because that won't achieve the target IOP over the long time.
Thank you,
Thank
sir,
you,
for
sir.
showcasing the bang
Yeah.
surgery and also highlighting the importance of doing mastering the skill of gonioscopy, especially for our residents, because now we don't only need gonioscopy for diagnostic purposes in the OPD or in the glaucoma clinics. The future is intraoperative gonioscopic related surgeries. So I think the take-home message for all the residents is to at least master this skill. And also important is important. The surgery is basically an assistant-based surgery. So your assistant also should be a well-trained one
Yes,
to undergo the surgery.
And I think if you don't want to do a retrap, then you should watch Dr. Vinay Gupta's now trabeculectomy, how to do a excellent trabeculectomy so that you don't require a retrap. This surgery is only for what I have shown is basically coexistent cataract with early glaucoma. But if there is a moderate to advanced glaucoma where you require low target IOP below 15 or 12, then of course gold standard is trabeculectomy, which is now going to be shown by Professor Vinay Gupta.
Thank you so much,
Thank you,
sir.
sir.
Thank
It
you,
was
sir.
a delight watching your excellent surgery.
The surgery went with a bang. So now we shift on to Professor Vinay Gupta, who will be showing us trabeculectomy on a patient of bilateral JOAG. The details about the patient is being presented.
We have a 26-year-old female with both eyes juvenile open angle glaucoma with right eye operated trabeculectomy with mitomycin C. The vision in both eyes is 6:6. The IOP in the right eye is 14 and in the left eye is 35 on maximum anti-glaucoma medications. The cup disc ratio in the right eye is 0.9 is to 1 with inferior thinning, and in the left eye is 0.8 is to 1 with inferior thinning. On the visual fields, we can see a biarcuate scotoma in the right eye, and in the left eye, we can see an inferior nasal step. So we have planned the patient for left eye trabeculectomy with mitomycin C.
So I'm going to do a phonics based surgery because primarily we have shifted from limbal based to phonics based.
So you don't prefer to use a traction suture before?
Yeah,
the
so
surgery?
I've used that Okinawa's speculum shika, and
Okay.
it tends to rotate the eye downwards without
Mhm.
having to use the traction suture.
Okay.
So the most important step is to free the posterior adhesions. As you can see here, I'm using the tenotomy.
Mhm.
So what the tenotomy does actually is mitomycin, it actually opens up the posterior structures so that there is a diffuse posterior flow of the aqueous.
So this is how much area approximately that you tend to cauterize and bear the sclera for? The dimensions of this area, sir?
So this is a young patient with juvenile glaucoma, and the question is to use mitomycin or not. Primarily because she's young, she has a long life to live. But over the years, we have seen that even for primary trabeculectomy patients and young patients also, low dose mitomycin is a good idea, primarily because it keeps the blebs diffuse posterior and therefore
So
long lasting.
what is your preferred concentration for mitomycin?
Yeah, so I use 0.2 milligrams per ml for about 2 minutes.
Okay.
It's just subscleral or subconjunctival or
This
both?
this is only subconjunctival. As I said, I tend to use less mitomycin primarily because because they are young patients, and the idea is that you have low diffuse blebs, and therefore you do not need very high concentration of mitomycin. So what I do is I use a blade breaker. I don't use the crescent primarily because it is a more controlled procedure compared to what you would expect with a crescent. So this, you see, as you move towards the limbus, the thickness of the sclera also changes. So when you're using the crescent, it is more or less a blind procedure. So here you can actually, with this blade breaker, you can actually determine the thickness of the sclera that you are dissecting. The other important thing, I think for the residents, it's very important to learn scleral dissection because this is where maximum number of problems happen. As you can see, as I'm closing the limbus, the closer to the limbus, it becomes thin. So does this blade breaker actually helps, apart from the fact that it is cheap, it also helps us to gauge the thickness and thereby do the dissection accordingly. Saline. Wash.
For resident training purposes, would you suggest the scleral flap to be on one particular side so that if it fails, the other side is available?
Yeah, absolutely. I agree totally with that. So I'm going to remove the mitomycin now. So so I don't put more than 2 sponges primarily because 10-0 nylon, primarily because counting and removing and all becomes very difficult. And I always use the Mirocell sponges. Mirocell sponges are better than cellulose sponges, primarily because the Mirocell sponges comes out in toto. Whereas with a cellulose sponge, you're likely that a part of it might just remain inside and cause problems. So therefore, this is a releasable suture that I'm using, and this is good because it acts not only as a releasable suture, but it also acts as an adjustable suture.
So you're pre-placing them before making the ostium.
So you take two, you make two loops, primarily one in the cornea and one in the scleral flap. The idea being is that that when you give pressure or to the globe or bleb massage in the post-operative period, you can kind of lower the IOP. This releasable will loosen. I think one of the very important questions is when to remove it.
Yes, sir.
So you need to remove them within 3 weeks, because after that, once the fibrosis sets in, then removing these sutures can become a little difficult. So as long as the IOP is well within 10 millimeters of mercury, you don't need to remove them. But once the IOP goes up, you can always pull these out on the slit lamp itself.
So they're just like two permanent sutures, but they're adjustable as well as
Absolutely.
releasable.
Yeah.
So any permanent suture also that you take, sir?
Yeah, so we'll give, in the end, we'll give a permanent suture in the center.
Okay.
So here you can see from there's one loop formed on the cornea that you can easily pull out on the slit lamp, and you don't need to cut it actually. You can just pull it out primarily because it's a knot on itself. In the end, you will see that it's a knot on itself, and you can just kind of cut it out, and then so this surgery takes a little longer time, but the idea is that you get diffuse low-lying blebs, which are good. So here we have shifted from the earlier limbal-based surgery to the fornix-based surgery, primarily because pilocarpine. So I'm putting pilocarpine. I always tend to put pilocarpine intraoperatively because I want a small iridectomy.
Yes, sir.
So now once you've done a paracentesis is also important, because in the end of the surgery, you would like to titrate the amount of aqueous outflow. You'll have to catch the superficial scleral flap. 10-0 Victor तैयार रखना. Now I'm going to do the internal ostium. Okay, so you can see the landmarks, you can see the bluish sclera, and when you make the internal ostium, be very sure that you are slightly anterior. So the ostium should be covered by the sclera on both the sides. And a very small iridectomy. Wash. So there's a lot of interplay of sutures in this surgery. And which means that post-operatively also you have to deal with all of these sutures.
So do you ever use vicryl sutures for placing the permanent sutures in
So this
trabeculectomy?
is a 10-0 vicryl Shikha that I'm using for
Okay.
the center
Mhm.
fixed suture. So the reason is that the 10-0 vicryl acts as an adjustable suture.
Okay.
So you can, it tends to absorb, and once it absorbs, then you can get a kind of a releasable action. So yeah.
So for pediatric cases, you're using only permanent sutures and no releasables.
Yeah, exactly. And there we're using
Vicryl.
again vicryl.
Okay.
So if this 10-0 vicryl if you're using, so don't you see hypotony?
No, it's pretty tight. So the idea is that you close the wound as quickly as possible. You do not want the AC to remain shallow for very long, and because there are so many sutures and there is a problem with that, so therefore it's important that we can close it. लंबा suture है. So this is the first releasable that I am going to tie up. So what you do is it's like a reef knot. So you are putting 3 knots, minimum 3 throws, and as tight as possible. Because in the post-operative period, you can easily kind of loosen this by giving a little bit of massage. I think trabeculectomy is more like an art, and you need to learn this art primarily because your experience over a long period of time really helps you in titrating the amount of intraocular pressure depending upon the kind of patient you have.
So other than the surgical skill,
Yes,
there's a lot of post-operative care that is required
Absolutely,
in these
yes,
cases.
yes.
So it's basically an art on the part of the surgeon and also on the part of the patient.
So you'd never use air for the intracameral installation?
Yeah, I mean, you can use the air, but in this case, we already, you see, now I wouldn't put air because I want to titrate the amount of filtration that is happening. And the air would give me a false hope that the amount of, that the AC is formed.
Mhm.
So if I put air at this point of time, I really don't know how much of filtration is happening. And I think this amount of filtration where the IOP, where the AC is not getting collapsed is just the ideal. So we have two releasable sutures where you have 2 of these loops which you can either pull out or you can kind of loosen in the post-operative period by giving a little gentle massage if the IOP is high. Even the end of the surgery in these cases is very important, primarily because this wound should be absolutely watertight.
Yes, sir.
Which means that all the aqueous should go into the bleb. If the aqueous leaks, then the bleb will not form.
Mhm.
If the bleb doesn't form, then the conjunctiva gets stuck to the underlying sclera, and that is the end of the trab.
So on the contrary, limbus-based flaps, they have less chances of post-operative early leaks
Yeah.
compared to phonics-based, but long-term they may have
Absolutely.
avascularity.
You are
and-
very right. Yeah, the limbal-based flaps are good in that way, but I think most of the studies have shown that the limbal-based flaps lead to avascular, cystic, horrible-looking blebs, which are not good for the long run.
And
Especially,
also very dysaesthetic for the patient
absolutely,
too.
yeah. Especially in young people, we do not want to put these. So these are the 2 side sutures which are
So these sutures you always do with the 10-0 nylon.
Yeah, always with a 10-0 nylon primarily because we don't want any leaks. You see, if you use Vicryl, the Vicryl starts losing strength from the first day onwards. And here we want a watertight closure so that all the aqueous goes posteriorly. So the closure of the wound in this case is very important. It is paramount that you close the conjunctiva well. You see, one of the other problems that can happen, which does happen if you try to use Vicryl to close the conjunctiva, is that you're going to get retraction of the conjunctiva. So that again is avoided if we use a 10-0 nylon. So that's
maybe
why
that is the reason we have not shifted to phonics-based flaps in very young children.
yeah. Yeah, in pediatric cases, we still do limbal-based flaps because this phonics-based surgery requires a long, rigorous follow-up, and
So do we have to remove these 10-0 conjunctival nylon sutures later on once the wound has healed?
sorry, I didn't get the question.
Yes. So these
Yes,
sutures
yes.
are removed post-operatively. So we always sit with the McPherson and all the stuff for suture removal in the OPDs also, because we have to remove the releasables as and when the patient requires, and the permanent sutures as and when they lose strength, we remove them. So that is why as a glaucoma surgeon, you have to have a very meticulous post-operative course.
Yeah, the idea is that you follow up because once the bleb survives the first year, it's going to generally do pretty well over the next few years. So she's, just to tell you a little bit about this patient, she's young, she has a family history of autosomal dominant juvenile glaucoma, and I've operated on the father, on the sisters. So she's the third member of the family having glaucoma.
So sir, did you call her for screening or she came herself?
Pardon?
Did you call her for screening or she?
Yeah, so she came with her sister, and we detected that she also has high IOP. So one of the very important thing nowadays in glaucoma is cascade screening. That means you screen all the family members, because the familial incidence of glaucoma is so high that it's important that all the family members should be looked at.
And the kind of glaucoma she is having that requiring trabeculectomy, it's good that she was screened in time.
Yeah, absolutely. And the family also has a rare myocilin mutation, just so that the audience know that some of these glaucomas are very severe. The very fact that she has come at such a young age itself means that that the glaucoma is very severe.
So you have overridden one suture with the others to leave it
Slightly.
without any stop gap.
Yeah, absolutely. So that there is no leak whatsoever. If there is a little bit of a gap, there is a chance that it might leak. So you can see that all throughout my suturing this time, the AC was well formed, which only means that the amount of filtration is just adequate, and I do not have to एक drop tropica might भी डाल देना. So I think the surgery is done. It is taken not too much of a time, and any other questions regarding phonics-based surgery are most welcome.
You had told that you will do a bleb massage. So would you prefer a bleb massage inferiorly as you've put the suture?
Yeah, absolutely. So on the slit lamp, if the IOP is high and you want to do a bleb massage to loosen these releasable sutures, you can just ask the patient to look up, and you can use a swab stick or something and just press very gently and see how the aqueous is moving. And you can actually see the aqueous diffusing into the bleb, and the bleb rising. So this is something really good with the releasable sutures, in that they kind of open up themselves, they loosen themselves, and they give very long, good blebs. So in the early post-operative period, the IOP is around 20s, 22s. AC is well formed. I mean, since we started doing this surgery, we hardly ever get shallow ACs post-operatively. There were times earlier when we used to do limbal surgeries and there used to be shallow ACs in the post-operative periods. Now with these releasable sutures, we hardly ever get a shallow anterior chamber. So the AC is well formed and the patient gets rehabilitated very quickly, except the fact that he has to come for regular visits for the suture removal. The long-term course remains quite good.
Thank you, sir. Sir, Praful here. So there is a question from audience. Why did you shift from phonics based to limbal based?
Why did I shift from limbal based to phonics based?
Yes, sir.
So I've given you the reasons, Praful, just now. The reasons why we shifted from limbal based to phonics based are the limbal based used to give us very avascular cystic blebs, which got infected. There was endophthalmitis and a lot of problems with those blebs. These blebs with a phonics based surgery are low, diffuse, and they are the blebs which would not lead to problems in the late post-operative period. So that is one reason. The second reason is that the phonics based surgeries generally have IOPs much lower than what the limbal based surgeries had. So all said and done, everybody has more or less shifted from limbal based to the phonics based, except in very young children where we still continue to do limbal based surgeries is because their suture removal and all of these stuff of regularly having to do EUS becomes very difficult. So yes, there are a lot of intricacies involved in this surgery, not only intraoperatively, but also post-operatively.
So sir has a lot of experience in doing slit clamp procedures for managing the complications of trabeculectomy. And sir does a lot of needling if required, if the bleb is fibrosed, and AC reformation also can be done on the slit clamp.
So the whole thing is that you can see that that this speculum is very good. The speculum really helps to avoid the use of a suture, a traction suture.
Sir, Ankur here, can you show the speculum, sir, once?
Yeah, absolutely. So this is a self-retaining speculum, Ankur. You can see it has, it is called Okinawa's speculum. It has the lower part is broader, and when you rotate, when you pull out the speculum, the eye rotates. I will tell you where to get it from, and it is really good for doing trabeculectomies.
Yeah, the lower flange seem to be larger than the superior flange.
Yeah. It helps the eye ball to rotate downwards for better exposure of the conjunctiva.
Thank you, sir, for such a nice surgery.
Thank you so much, sir. It was a
Thank
delight
you, sir.
watching a surgery.
ठीक है, बढ़िया हो गया. ठीक हो तुम, आकांक्षा?
So any questions from the audience? So is the next surgery ready?
15 minutes. Just for the for our residents, I think we have all shifted to.
Next case.
The next case is ready.
Okay, so I think would like to call upon for the next session, Sebismus live surgery. I would like to call upon our esteemed panelist, Dr. Swati, Dr. Rebecca, and Dr. Amar to come upon on stage and take over the mic.
Thank you to our esteemed panelists from the earlier session. Thank you. Moving on to the next surgery, I would like to invite our esteemed panelists, Dr. Digvijay Singh, Dr. Swati, Dr. Rebecca Dhiman, and Dr. Amar Pujari. Welcome, panel. We'll be starting off with the next surgery, subjected on strabismus surgery. I would request our esteemed panel to please take their seats.
A very good morning to all in one. So we have a case of strabismus live surgery today. This is a case of a 12-year-old male child who is brought to the RPC OPD with chief complaint of inward deviation of the left eye since early childhood. The patient has a best corrected visual acuity of 6.6 in the right eye and 6.24 in the left eye, with the refraction of 2.5 diopters spare in the right eye and 3.5 diopters spare in the left eye. There was slight amount of decrease in the amount of deviation on wearing glasses, which was suggestive of a partially accommodative component. On extraocular movement examination, we can see that there is a bilateral inferior oblique overaction. The amount of deviation was 50 prism diopters in the primary gaze, and it was 45 in the up gaze and 60 prism diopters in the down gaze, which is suggestive of a V pattern. So the diagnosis of partially accommodative esotropia with V pattern with left eye strabismic amblyopia was made. The fundus photo demonstrated presence of bilateral fundus extorsion. So the plan here is to go ahead with the right eye inferior oblique recession with anterior positioning with the modified Elliott and Nankin methods. And left eye, we will be doing medial rectus recession 5 millimeters with LR plication 7.5 millimeters and inferior oblique recession of 10 millimeters. So over to the surgery OT.
Hello, good morning, sir.
Good morning, everybody.
Good morning, sir.
Good afternoon and good evening for people logged in from different parts of the world. Welcome, everybody, and thank you, members on the dais. And again, I will be assisted by Dr. Shivani, our junior resident, and Dr. Monica, the senior resident. And you've just seen the plan. The aim is to do a medial rectus recession first. We always start with recessions, although it's more conventional, but if there is a mildly tight FDT, it makes it a little difficult to do a resection or application. That's why we'll do the medial rectus recession, followed by the inferior oblique and the lateral rectus from the same incision. I have virtually completely shifted to application instead of a resection, unless there is an indication for a section, like if we have to do shifts. But we've even tried shifts with applications, although it's not as neat as a resection would be. So that's why application, we would be using a fornix incision, again, virtually shifted to a fornix incision completely. It causes less bleeding, it's faster, better closure, unless again it's indicated, like in conditions where there is a tight post-suction test, or we feel that we may have to recess the conjunctiva, or in elderly patients where the conjunctiva is very friable, so the conjunctival incision may open up too large, so it's like not so great. So that's the place where we are going to use a fornix, a limbal incision. The other indication would be if you want to do a very large recessions or pardon procedures where posterior access can get a little limited by a fornix incision. So so that's the plan. While the patient is being clean and draped, any questions or any discussions, esteemed panel on the dais can of course handle most of them.
And since it's a partially accommodative squint, so we must also have this in mind that we have to just correct the part of the squint which is left after the correction with the refractive error. So first you need to do a proper cycloplegic refraction, age appropriate cycloplegia. Whatever amount of squint is corrected by the refraction, for that you have to prescribe glasses, and whatever is the residual amount of squint, it is for that the surgery is indicated.
Yeah, truly, that's the most important thing, because over time we expect as the child grows, the hyperopia to reduce. And if you are not careful, the patient may come back with the consecutive exo, which would require a resurgery. So it's always very important to be sure of the angle you wish to correct.
In the meantime, you may also discuss how you plan surgery in a particular patient. As Rebecca said, that first and foremost thing is, of course, a well done cycloplegic refraction and proper prescription. So other factors also can be taken account when you plan for surgery.
True. The other factors, particularly whether you're operating under general anesthesia or local anesthesia, whether you want to do both the eyes or you want to do one eye. Really, no studies have shown any significant difference in outcome with one eye versus both eyes. But the advantage of doing one eye is that under local anesthesia, of course, it's easier on the patient, but corrections can be more if you do one eye recess resect or recess plicate procedure, because you get almost a 25% advantage by operating one eye as compared to spreading the surgery in both the eyes. Of course, doing both the eyes is more advantageous. You don't have that much palpable fissure changes. You don't have problems, long-term problems, the patient having to be patched or having pain in both the eyes. So these are advantages of one eye versus both eyes. I think the patient is ready. So while you discuss, we'll just move on to the
Yeah,
surgeon's
definitely,
view.
definitely.
उस साइड से करना है ना? ध्यान से ये इसका
And
ये
since
लग रहा
also
है.
it's a very large angle strabismus, so it's always better to do unilateral resection or plication procedure for large angles.
निकाल
Then
दो.
bilateral recessions may not be so effective
दो.
for such a large angle
ये
strabismus.
निकाल दो.
हाइट बढ़ा देता हूँ ना, स्पेस कम कर देता हूँ, फुहारे लगाने से स्पेस reduces.
So your microscope view is now visible, sir?
Great. So as I said, we'll start with the medial rectus. Focused. Any issues, please?
Yes, sir. It's well centered and focused.
Great. So we start with the limbal traction suture. We use a cotton suture. Hold the eye at the inferonasal limbus, pass the suture from there. For the inferomedial fornix, we apply it here. For the inferotemporal fornix, we'll apply it on the lateral side. You identify the medial rectus. Here you can see the edge of the medial rectus. It helps to make sure that you have not rotated during the time of traction. You place the conjunctival incision horizontally and the tenons incision a little vertically. In children, we tend to have a lot of tenons, so it may take a multiple snips. You need to go right down to the.
So can we reduce
White.
the brightness a little bit because it's too white actually?
Okay. So you can see the white sclera. The white sclera must be shining. But yeah, if you could. So you need to see the white sclera before you make the opening. You take the untooth or the Jemisin's hook, you press the sclera a little and you hook the medial rectus. So that's your hook of the medial rectus. You take the Green's hook, which has the muscle, which has a tooth on the tip, and you press and pass. The importance is, this is the pole test. You can bring it to the limbus, showing that the entire muscle has been incorporated in your hook. When you are doing this bimanual procedure, you lift the tip a little so that the muscle doesn't slip out. You make an opening at the tip of this, and so here you need to confirm that you have the whole muscle. You don't want to split the muscle. So you've confirmed this, that the whole muscle is there. A lens hook on the inferior side. The assistant will lift it straight so that you can make these, you can identify these without damaging the sheath.
So if you could center the screen. Yes.
Hope that's okay.
Yes, sir.
Great.
Now it's
So that's what I was saying. Once they, could you pass it again, please? Yeah. So these get lifted. Depends upon the amount of dissection you wish to do. So now you have identified and cleaned the insertion. We're going to pass the sutures. So if you have an uncut 6-0 vicryl, you'll pass one center. The important thing always is to identify the vessels. and if possible, pass around them so that they don't bleed in the period when you've cut the muscle. So you have this central knot, which will prevent a bit of the sag once the muscle has been sutured, and you pass sutures on either side of the central muscle. So this is the lateral side, inferior side. This will be the superior suture. Like I said, we'll try to incorporate these rather angry looking vessels in our suture knot.
You can also use cut sutures for this. In that case, you can pass it from either end. That's a personal choice in how you want to do it.
Yeah, also if you're doing an inferior oblique before,
Yeah.
then you have a cut suture in
Then
the
you
end.
have a cut
Yeah.
suture.
Yeah, one word I generally would prefer to do the IO first. You like an uncut for the, so we'll now cut the muscle. So decision making varies more so because of the amount of stump you leave behind, how much where you pass the sutures. So these were rather okay. That's how. So I leave a very small stump behind. So my decision making is incorporating that little amount of stump that is left behind. Mark, please. 5. The cut muscle would bleed because superiorly. We need to make sure we are perpendicular.
And it's always a good idea to hold the two edges separately when you put the two marks, rather than holding it at the center maybe. Because
So yeah, you can always rehold them. Just need to make sure that you don't hold it at the place from where you're going to make your measurement. Otherwise, you will distort it.
Right.
If you pull in the middle only, then sometimes it the problem is that you may not get the easy maneuverability to get the positions marked. So you've passed the suture superiorly.
You will tend to extend the incision if you hold it in the center, because then the assistant is going to pull the conjunctiva more for you.
Inferiorly. Just swab it once. Rather strong vessels near the insertion. So
right.
Despite that passing sutures, we were unable to stop the ooze. But this will stop the moment we pull the muscle towards the new insertion. Just remove the lens hook. Yeah, lens hook again. One more. Yeah, so there should be no tissue here. That's the most important thing. There should be no tissue at the insertion when you are closing and tying the muscle sutures. Okay, so we'll close. Yeah, another 80, please.
Yes, now the ooze has also settled down. So So that's how we close the conjunctiva. We are using the 80 Vicryl.
That's the beauty of phonics incision. It closes with minimal suture and is aesthetically more acceptable than the limbal incision.
Symbol based. It's not visible at all as soon as you remove the speculum.
Yeah, even in the post-op, there's hardly any limbal disturbance, and at times, especially in children, you even can't make out the eyes being operated for a
Preservation
squint
of
surgery.
limbal stem
We-
cells. You can
Yeah.
have.
We'll change sides now for the inferior oblique recession and plication of the lateral rectus. Just wash the cornea, please. Are we focused?
Yes, sir. Focus.
So now, like I said, we will now be placing the suture in the inferotemporal limbus. Again, hold it here. You can see this rather prominent vessel. We need to try and avoid it, although it comes almost always bang where we want to make the incision in the fornix. So you identify the lateral rectus. This is the lateral rectus. You need to make sure that you don't hold the fibers of the lateral rectus, and to make sure that there is no torsion. Can we change the scissors? You can use it as a clamp in a bit. So we go down to the sclera. You can see the white sclera there.
Right.
That's ensuring that you're in the right plane. The other important part in this is to go parallel in your opening, go parallel to the margin of the lateral rectus. Otherwise, you will meet a vortex vein, which is just a little inferiorly. Lens hook. So all your maneuvers have to be close to the insertion of the lateral rectus. So now you can already start seeing that fleshy lens hook, muscle hook, untoothed.
There are a lot of things that you need to keep in mind when you want to hook
So when
inferior oblique.
you go down, you lift it. You can see the posterior intermuscular septum, the white
Right.
posterior intermuscular septum. You can remove the lens hook, please. And this is how you'll make sure that you have all the fibers. You can see the white posterior intermuscular septum there. Spring scissors. So now you focus up. You make an opening here. A lens hook, please. Yeah. So again, you can pass the length, you move the lateral rectus away. You see the insertion here. You can see the inferior oblique insertion. People cut it away from the insertion, but it's always better. People were afraid that the macula, which is underneath it, can get injured, but there is no reason why the underlying macula is going to get injured. So you disinsert the inferior oblique completely. This is now the disinserted inferior oblique from all its attachments.
So
Everything can be removed.
That's one muscle which you can disinsert without any fear of losing it.
Yes.
And also, I would like to point out that it's not as simple as sir is making it, look.
Yeah.
Because inferior obliques are actually the difficult muscles to deal with.
This is what one can call the pigtail sign, just to make sure that this is the posterior part of the muscle. Sometimes it gets rotated in your maneuvering. So to identify that this is the posterior, this is the anterior. You'll have that curl of the posterior end. Oh, this is a fresh suture. So we are lucky to get a fresh suture today
Also,
for
if
live
you are
surgery.
very careful, then the muscle actually splits into two.
Yes.
So it's fanning out at the insertion. So you have to be very, very careful when you're doing inferior oblique. And leaving
Some
the posterior.
residual fibers may be
Yeah.
there, which may leave later in residual inferior oblique
Yeah,
overaction.
if you leave the posterior fibers, the surgery would be ineffective.
So we pass the sutures at the insertion, at the end of the cut end of the muscle.
So this patient has asymmetric
it.
inferior oblique overaction and therefore an asymmetric surgery has been planned for it. The amount of extortion is more in right eye as compared to left eye.
Yeah. So this is the other attachment to the inferior rectus. We cut this so that there is no pull of the posterior part of the structures anteriorly. We planned for the left eye. So we have a 10 mm recession of the inferior oblique. Now, there are multiple ways in which this can be measured. What we prefer is to use the Parkes way to measure 10 mm. We use 3 mm and 2 mm here. So this would be the Parkes point where we're going to pass it. The Elliott and Nanking passes the sutures here. Modified, which we do, will pass the sutures posteriorly so that there is no pull on the posterior fibers. 3 mm, 2 mm, 3 mm. 3 and then 2. So we have 3 mm here, if you can see, 3 mm marked from the insertion of the inferior rectus, and then 2 mm laterally. So this would be equivalent to a 10 mm recession. So we pass the anterior suture just about here. And we pass the posterior suture about 5 millimeters or so posteriorly to get an even spread of the muscle. So that's the posterior suture. You get an even spread of the muscle. You can remove the lens hook, please. We'll place the lens hook again here. Once we have passed the muscle, we make sure that there is no tissue here at the insertion. Spring scissors.
How do you decide how much surgery for inferior oblique has to be done?
So it's as per the inferior oblique overactions. So it will be a graded recession. You have 6, 8, 10 mm of weakening, followed the further weakening is the modified Elliott and Nanking. And if you have a superior oblique palsy or a DVD, you could do an Elliott and Nanking or a +2 station where the Elliott and the muscle is inserted about 2 millimeters anteriorly. So based on your IO overactions, you will do the amount of IO weakening procedures. We can remove that. So we've done the IO, we move on to the lateral rectus. So the procedure of hooking remains the same. I've hooked the lateral rectus by the Jamisons, followed by the greens. So you press it a little and then you come onto the medial side. Make sure that you have the complete muscle.
Some surgeons do prefer to do a symmetrical inferior oblique surgeries. And sometimes, what is your opinion about it?
So once we know if there is an asymmetric overaction, you can place the lens hook here. Based on the overaction, whatever amount you want to correct, I think that would make sense. You would not do a symmetric muscle surgery for horizontal recti. You'll do it based on the amount of deviation. So similarly, why would you want to do a symmetric IO if there is asymmetric overaction? So we have graded procedures, ungraded procedures like myectomies and tenotomies we don't prefer to do because it's always advantageous to have control of the surgery and don't let fate or other factors take a call on how much effect each surgery is going to do. So, and we're going to do plication. We're going to measure the amount of plication, which was 7.5 millimeters. So a mark of 7.5 millimeters first. Another lens, so please. So you make sure that you have an appropriate, always check. Sometimes there may be errors in that gently. So you go and mark on the muscle, the place where you're going to pass the sutures. Okay. Posteriorly, just take this. So you can use another muscle hook underneath the muscle to make sure that you don't hit the sclera posteriorly.
Maybe for the beginners, they can put another muscle hook underneath where they are passing the suture in plication.
Yeah, it definitely aids in making sure that you have the complete muscle when you're passing through.
Right.
It's a double arm cut suture. This is recession where we
So
single arm cut
these are
suture.
two single arm
Yeah,
sutures.
Two single arm cut sutures.
So you can see this is the other end of
recession.
the
Yeah.
suture. Swap stick, please. Reverse.
It's important to take the entire muscle into the suture while we are passing the suture.
So now we move anteriorly. You can remove this, please. Bring this anteriorly. For plications, because
So
we are
need to
using
center the video.
we are better.
Yeah.
So as in resection, we are using, as of now, we are using the same nomograms as resection. You need to pass your suture for plication just anterior to the muscle insertion, because in resections, you used to pass it through the muscle stump. So you don't want to vary your amount of muscle that you're going to plicate as compared to resection. So that's why you're going to use pass it as close so that the nomogram does not require any changes. So I haven't changed my nomogram between resections and plications. So you pass it just anterior to the insertion. So both the sutures are now passed anteriorly. Now we do another, we go back for another loop.
So it's like a box we are plotting on the muscle.
So, or it's basically a horizontal mattress suture. There we are. So you can see the two loops of the superior suture. This is one, and this is the other. We place them both here. This is the first loop of the inferior suture. And we.
As sir was saying, if almost many of us have now shifted to plication rather than resection. It has its own advantages. One, it is vessel sparing. Two, the chances of muscle being slipped are less, which is much more common with resection, where you have tension in the muscle build up post-operatively and the muscle may slip. So plication, and to certain extent, maybe for a few days, could be reversible also. Less,
So
less
these are
messy as well, yes.
So we have the loops. We have the pull of this. These are the two sutures we're going to pull. The two long sutures we have passed, and these are the ones which are the tails which we will tie. We can use an iris repositor here to make sure that lens hook, please, posteriorly. Yeah. Move it posteriorly. Another one inferiorly. Gently. Yeah. So when I pull anteriorly, the loop goes in posteriorly, and I can make the tie without having. You can pass an iris repositor. Also, you can remove the lower one. Hold
Yeah,
this.
so we can see that the muscle has folded so well.
So it folds in inferiorly. You can make sure that the loop does not come up front.
I think here the anterior bites have to be really strong ones, otherwise it can slip back and give you an undercorrection because the.
So they are, that's the modification, I think, from the initial days of plication, where they were doing muscle to muscle plication. This is a muscle to sclera
plication. Yeah.
And I think that's the reason plication is back in picture.
Yeah, I tried a few plications, but then I had a undercorrection in a couple of patients. So being in private practice, I again shifted back to resections.
Then so you tried the
muscle to sclera.
Sclera.
But still, if the bites are not so strong, then
Yes.
you can just, if one of the sutures gives way, then it's a half plication kind of thing. So
So we are done with the plication also. You can see the posterior folds there of the muscle underneath.
Yes.
Pressing
That
on the
makes-
sclera
yeah.
over time, that will just get absorbed.
So having
s-
posterior fold makes it more cosmetically acceptable rather than
we'll-
the anterior fold, which can be visible through
sclera.
conjunctiva.
Yeah, conjunctiva.
So we close the conjunctiva exactly the same way we did on the medial side.
So personally, what has been your experience with plications versus resections?
So as like I said, we haven't found any significant difference in outcomes. So we use the same nomograms and persist with plication. But a little anterior passage of the suture is probably compensated for by a little gap between the two as the muscle folds on itself.
Okay.
So more or less, we have the same results, and I haven't found any reason to change the nomograms that have been used. And even for late recurrences, we haven't found any undue increase in late recurrences since the time we have shifted to plication as compared to resection. So
Right.
no reason to think. You need to always check during this maneuver on the lateral side, this suture had come out. We can get an 8-0 again, so that we need to close it. So we close this. So that's with the surgery that we had planned. Of course, I think we will be, any questions we can take while the next case is being prepared. Post surgery, you must always do a post-suction test fixation, please, to make sure that your resection oblique plication is not causing any limitation of movement. So that's very important. Just identify, particularly on the lateral side, the wound, the conjunctival wound. Sometimes you may have in children a little prolapse. Need to just press the conjunctiva together so that it sticks while the eye is bandaged, and you won't have any Tenon's prolapse in the post-op period. So this is for this eye surgery.
That was indeed quick.
So thank you everybody on the dais, and Dr. Shivani, Dr. Monica for the assistance.
Thank you, sir, for such a wonderful surgery. So I guess if we have
Yeah,
any
the other
questions,
item.
then we can take up. Otherwise, we can move on to the next live surgery session,
Wait,
which is the ptosis surgery.
we have one.
So I would like to call upon the panelists for the next session. Dr. Neelam Pushkar, Dr. Rachna Meer, Dr. Maya, Dr. Anita Sethi, and Dr. Mukesh Sharma.
Thank you, Dr. Rebecca, for making my job easier. And thanks to all the panelists and our speakers for the previous presentation and the live surgery. Moving on to the next session, which is the ptosis surgery. I would like to take the honor to invite our panelists, Dr. Neelam Pushkar, Dr. Rachna Meer, Dr. Maya Hada, Dr. Anita Sethi, and Dr. Mukesh Kumar. The surgery will be presented by Dr. Mandeep Bajaj. Welcome, Dr. Mukesh.
Yeah, good morning.
Morning, sir.
So I guess everything is ready, and We have had wonderful sessions of squint and glaucoma surgeries. I witnessed just now surgery of Dr. Rohit. That was wonderful. And now I think we look forward for Dr. Mandeep's surgery. And I am very confident that we'll be having a real treat to watch. Good morning, sir. It's Dr. Mukesh.
Good morning, everyone. My name is Dr. Parag. I will be giving the details of a case for ptosis surgery. So, the patient is a 24-year-old male who presented to RPC OPD with chief complaint of drooping of right eye upper lid since birth. There was no diurnal variation, and the ptosis was non-progressive, and there was no associated history of trauma. Birth history, systemic history, and family history is not relevant to the, not significant, and they're not relevant to the case. On ocular examination, there was no significant findings. It was within normal limit. So on ptosis examination, the face of patient was symmetrical. There was no anomalous head posture and no frontalis overaction. On ptosis measurement, MRD1 in the right eye was 1.5 mm, MRD2 was 5 mm, and VPH, vertical palpable aperture height, was 6.5 mm. In the left eye, MRD1 was 4 mm, MRD2 was 5 mm, and VPH of 9 mm. So we can conclude that there was a ptosis in the right eye of 2.5 mm. LPS excursion as shown in the pics. In the right eye, it was 9 mm. In the left eye, it is 14 mm. There was no lag of Selmos, no lid lag, and Bell's phenomena was good in patient. So we can conclude that the patient had right eye congenital simple moderate ptosis, and our plan for surgery would be right eye LPS flexification under local anesthesia. Thank you.
Okay, very good morning to all of you. Dr. Bajaj here. So as you have just heard the clinical details of the patient, he is a patient of unilateral moderate ptosis with good LPS action. Ptosis of 2.5 mm, sometimes it even is about 3 mm. So he's an ideal candidate for LPS plication. So I just heard the squint people talking about plication. It seems that it's quite infectious. It's spreading to other units also. So that just ratifies the popularity of the procedure. So people in squint also have possibly started switching from their resections to plications, which is a very good sign. So here we are. We are just about to now start the case. Beta ऊपर देखो जरा सीधा. देखो light. थोड़ा सा. So now first of all we'll mark the lid fold. You can see the natural lid fold is just about 5 millimeters from the lid margin. So now I'm just marking the lid fold. The other ways of marking the lid fold are that if the natural lid fold is not so prominent or there are multiple lid folds, then you try to, sort of make it symmetrical with the other eye, and you can mechanically lift up the lid and see where the most prominent lid fold is forming and which is symmetrical with the other eye. So these are the criteria for marking your lid fold. So now we will be giving the local anesthesia, and in these cases and in all other eyelid cases which we do under local, we prefer to give the frontalis block, which is also classically known as the front block of Hillbreath and Silver. So we ask the patient to look down. नीचे देखिए, दोनों आँख खोल के नीचे देखिए. We ask the patient to look down, and then at the midpoint of the upper orbital wall, we just go in just near the superior orbital wall. About the classical block says 40 millimeters, but 40 millimeters is a bit on the higher side, so about 2.5 centimeters is fine. We inject about 2 cc of Salucan with adrenaline. So since this is a purely sensory block, it is ideal for surgeries where you need to have retain the motor function during the surgery. And you can, if you want to titrate something, or you want to see the LPS in action, you still have the motor function intact.
There is some disturbance with the, I think the signal that's coming from the microscope, because it starts to break in between. So we can,
Okay, we'll
the
try to fix
audiovisual
that.
team can just see that
Yeah,
the
okay.
connections are good.
Yeah, I'm told that they have fixed it. So now, please, can you give us a feedback if
Yes,
it's
yes,
okay
sir.
now?
It's okay now, sir.
Yeah, okay, great.
Sir, how much volume would you advise for the injection so that it does not diffuse into the LPS also? I mean, what would be the ideal for?
1.5 to 2 cc is ideal.
Right.
And then these are the advantages of this block. A couple of disadvantages are that it does not anesthetize the extreme lateral and the medial. I look in with 26 again. Extreme medial and lateral side of the parts of the lid. So we do prefer to give a little infiltration also in the suborbicularis plane. So there are three advantages of that. Firstly, it will give you a cleavage plane there when you're doing your dissection. Secondly, you will get good hemostasis because of the adrenaline. And thirdly, your anesthesia, right? So we'll just go on down there and give a little infiltration also.
So do you consider doing MMCR also for moderate doses, or your preferred surgical technique is this only, levator plication?
Sorry, what is the question?
Do you prefer doing Muller's muscle conjunctival resection also for moderate doses, or your preferred choice is plication only?
Conjunctival mullerectomy for say up to 2 or 2.5 millimeters of doses with the good LPS action, and provided the phenylephrine test is positive. So that is our this thing, that will be falling in the range of the conjunctival mullerectomy. And if the ptosis is more than that, little more than that, then up to 2 millimeters is fine. If you have say about 3 millimeter of ptosis, you'll have to possibly include a bit of tarsus also. So it goes into the tarso-conjunctival mullerectomy range. So we should wait for a sufficient period of time to let all the infiltration diffuse out, so that your normal landmarks are not distorted. Then I got into it. Tooth forceps. Tooth 1 into 2. And now we are passing the stay sutures. So previously we used to pass 3 stay sutures, but 2 sutures are more than enough. One at the medial limbus, one at the lateral limbus. They give us a good traction. So while passing these sutures, you should stay away from the marginal arcade, because if you go a bit too much, a bit higher, you're sitting on the marginal arcade. So that will lead to a lot of bleeding and a hematoma formation. So that precaution one has to take at this stage. So once we have the stay sutures in place. A lid spatula is smeared with ointment, is applied with the convexity, the concavity downwards. इसमें 100 डाल। And then now we're going to just start our lid crease incision. So I would like to warn some of our beginners that while giving the lid crease incision, one should err towards a little superficial side only, that is skin and partial orbicularis, because sometimes if you are too adventurous and you go down a little more, at this stage only you can damage the levator epineuritis. So now I'm just I'm just splitting the orbicularis fibers now.
I think we can very clearly see the nerve fibers at the suborbicularis level that are traversing the lid vertically.
Yes, absolutely.
Even the orbicularis muscle horizontal fibers barely over there.
So just put a retractor here. Let's keep it pressed for a minute. Wait, take it out, take it out. So let from the corner. So
Yeah, so for the beginners who just started doing ptosis surgery, I think it's very important to be careful with your incision, like sir emphasized that you do not have to make a very deep incision. It should only be skin deep. And the way that you can ensure is that by keeping adequate traction on the skin. So when you're giving that incision on the skin and you have an adequate traction on the skin, you can just see the edges of the wound parting as you give the incision. And again, your dissection has to be vertical to, so the opening of the blades, like you can see in the video. So it's dissecting the orbicularis and the blades are opening perpendicular to the horizontal surgical wound. So that's very important to realize. That's how you have to dissect the orbicularis. And you know that basically prevents the injury of the underlying. Yes.
okay, so like it was mentioned that the orbicularis fibers and the epineuritis can be easily differentiated. Orbicularis being horizontal and fleshy, and the epineuritis is vertical and epineurotic. Yeah. So now we're just opening the orbital septum, and you can see the orbital pad of fat herniating out. And here I would emphasize that one should open it properly, not partially, to get a good dissection of the levator beneath that. So this is a very important landmark in this surgery and all ptosis surgeries, because now we are sure that whatever is below this is the levator and we are in the right plane. But when you are doing your repeat surgeries, or the post-traumatic surgeries, residual ptosis, then the septum can really play tricks with you. It can grow, under, over the levator in all sorts of directions. So then the landmark is not so reliable. But in a fresh case, this is extremely reliable.
This is a very important landmark, like Sir said. Again, it's in the subseptal and pre-eponeurotic plane. So it's very important to identify this, to be able to get to the right plane and to be sure that you're working in the right plane. And once you see the fat pad, you're absolutely sure that you are underneath the septum and over your aponeurosis. And often if you are unable to see that fat pad, especially in younger patients who have less of fat, the trick is to just maybe press the globe a little bit and you can see the fat prolapsing then. Sometimes, rarely, you may not actually see the fat initially, but on pressing the globe, it might just prolapse out and you get to see your plane. And sometimes you can even reposition your spatula. Yes. Slightly just take it out and helps in bulging the.
We
fat.
can't hear you. Can you speak a bit louder, please? Reposition the microscope, you said?
No, sir, nothing. Ma'am, we were talking about the non-visibility of fat pad at times in thinner patients
Okay,
where.
all right, all right.
Yes,
No, no.
yes. I usually tell my resident to keep the spatula 45 degrees angle and with slight pressure over the eyeball so that we have sufficient working space between the LPS and the roof of the orbit. Because if it is pressed against the bone, then dissection becomes difficult.
Another important thing one should do is that one can palpate the aponeurosis and see that there is no damage. You can just, whatever is below your finger is, if there's sufficient tissue below your finger, then your aponeurosis is fine. So one should in between palpate a little and see that you're in the right plane. The visual clues will of course guide you, but you should physically also check that your aponeurosis is. Otherwise, if you just feel the spatula below your finger, that means you're just onto the conjunctiva. And then to take the dissection more posteriorly, we use a blunt dissector. The lens spatula comes in very handy in these cases. So we have sufficient aponeurosis now to plicate. We are not going up to the Wittnalls in this case, which is not required. You should realize the anatomy that the orbital septum is inserted at about 10 millimeters above the superior tarsal border, and the Wittnalls is at about 20 millimeters from the superior tarsal border. These are the average measurements, ballpark figure. So, if you want to just have a rough idea where exactly the structures are. Like this was the insertion of the orbital septum which we have cut, and then the Wittnalls is a little behind this. So I usually do not dissect towards the tarsal plate on this side, because in mild to moderate cases, just a bite through the pretarsal aponeurosis here and a posterior bite are more than enough. But yes, if you do need more of a lift and the LPS action is not so good, then I would recommend that you go down below the orbicularis on the tarsal side also, dissect a little anteriorly, and which will give you that extra millimeter or 1.5 millimeter of lift and give you a little more sustainable correction in those cases. Okay, now you can give me the calipers, please.
Sir rightly said that if you want the procedure to be more effective, then it's better to be like, 1 to 2 millimeter from the border of the tarsus and take a bite from the tarsus.
Yeah, I don't take a bite through the tarsus. I take it through the petrasal levator only. But in some cases, when I need a, like I said, in more severe doses and in cases where you need the extra lift, then I do that.
So you
But
could
in
be
this
doing
case,
a-
we are very lucky that he has a very good LPS action, and we do have this thing moderate doses. So we have to be little more conservative in this case rather than going over, because there is a chance of overcorrection in those cases. Like
So we could be doing application which is involving the aponeurosis, or we could take the bite through the tarsus depending on the action of the LPS and the amount of doses. So in this particular case, we are planning to, sir is planning to take it through the aponeurosis, and it will be basically a muscle to aponeurosis kind of application, like we were discussing in the previous session in squint also. The application could be through the sclera, or it could be a muscle to muscle application.
yes, absolutely. So that's the strategy.
Sir, is there some chances of late droop in these cases where you are not passing your sutures through the tarsus? There is no rigid structure actually. So with the healing procedure, gradual healing, you may have some droop in aponeurosis to aponeurosis suturing.
Well, previously we used to see that, but nowadays we have modified our technique a little further. I'll just, as we go along, I'll tell you.
Okay. Okay.
And I think we also need to be careful about the sutures that we are using for plication. So unlike in resection where we use absorbable sutures, in plication, we tend to use non-absorbable sutures. And so that is
Yes.
something that needs to
so,
be remembered.
So in
Yes.
these cases, we can use, like we normally use 6-0 nylon or 6-0 proline.
The LPS is visible very well. It's looking, I mean, clearly visible.
Yeah,
and
so
on the screen.
This gentian violet is, the spreading of the gentian violet is just to signify holy for you people. Otherwise, we would have just put a very thin line there. Okay. All right. So you can have the suture 6-0 nylon. So previously, in my previous videos, you must have seen that we used to use a double arm suture and then take it, from across the horizontal bite and then up. But nowadays, we've even made it simpler than that. We are just using straight bites, just through the pretarsal tissue there. Yes, you must take a very deep bite there, because yes, if you take a superficial bite, you might get a little this thing, late droop, like Dr. Mukesh had mentioned.
And I think the other advantage of doing aponeurotic plication is that we are not really dissecting and cutting the fibers which are going and making the lid crease. So we don't have to really recreate the lid crease. We don't have to pass those lid crease forming sutures. But if we are planning to pass it through the tarsus, then we have to do that dissection and cut off those fibers. And so at the end, we have to remember to reform the lid crease.
Yes, that's what.
What is the amount of plication you are doing?
we do 12.5 millimeter in this case. Generally we use in cases where we have a good moderate to good LPS action. दोनों आंख खोल के ऊपर देखो लाइट में देखो नीचे देखो थोड़ा लाइट में देखो हाँ देखो लाइट में देखो. So there we need to about 5 millimeter per millimeter of doses, subject to a minimum of at least 10 to 12 millimeters, subject to a minimum of 10 to 12 millimeters and a maximum of 20 millimeters when you're at the Whitnall's there.
So what about cutting horns?
Sorry, no, we don't cut the horns in this.
If
We did,
suppose-
yeah, we did do a study where in Marcus gun ptosis, where we did the cutting of the horns with LPS plication. That worked quite well. Reduced the Marcus gun to some extent.
Sir has done a lot of work on plication in different grades of ptosis and has also published some of his good work with excellent results. So this surgery as such is very physiological, reversible, and very good for the beginners. And it really worked well, even in severe ptosis with almost say 4-5 mm of LPS action, this surgery worked. So would you like to share some experience with the severe grade of, you have done a study also,
Yes.
if I remember correctly?
Yes. So, when initially when we started doing plication, we were under the impression that it works only in mild to moderate ptosis with fair to good LPS action. But then we did start getting good results with a large plication, taking the support of the Whitnall's. So as long as your LPS action is at least 4 millimeters, and your ptosis is, even if it's severe, you can get get away with a large plication and get your correction properly.
So in the large ptosis, do you get some more lid lag or
Yes.
lag of thymus? Is it more pronounced?
Yeah, initially for the first about 2 to 3 weeks, we have to really keep a watch on the cornea and keep the frost suture for a little longer. But then with time, it usually settles down. Yes, of course, we do have to keep a very strict watch on the cornea in those cases. Keep them very good tear substitute and lubricant cover. And sometimes if things are not really going in your favor, you might need to readjust a little bit. Now let's contour. देखो बेटा ढीला छोड़ो आंख को, ढीला छोड़िए और देखिए retracted.
So we can see that there is lag of thymus, and that is one indirect way of assessing that yes, your plication is working. So
Yeah, we can already see the effect coming. Now
Yeah.
we'll just see the contour after this.
even the contour you can,
Yeah.
and the lag of thymus there.
Small. Flush.
So basically you have changed the suturing from horizontal mattress to a vertical mattress now.
Yes, actually, we were wondering what are we going to show now. It's become so simple that even the beauty of this is that a person who doesn't have a high volume oculoplasty patient load, and then they do not do ptosis that often, even they can pick up the the learning curve is not so much. They can pick up the surgery very fast and replicate the results. So that is the real, it's physiological, it's reversible. If there is an overcorrection, you can easily adjust that overcorrection. There is not an issue.
Yeah, and I think so with this kind of a suturing, the chances of slippage will also be lesser.
Yeah, that's what we are getting more sustainable lifts.
Yes.
Less of recurrence of the ptosis, and sometimes with our previous configuration, that was a problem in some cases.
So what about the bunching of tissues? Any problem, any persistent edema or swelling visible the post-operative period because of
Not really, it settles down. Initially, there is a little effect of the bunching, but yes, some patients, maybe 5% of the patients might get a little, they might require some NSAIDs in the long term. But otherwise, in the majority of the cases, we don't see that.
So in the severe ptosis, do you also do a skin muscle excision to kind of decrease the bunching or the skin fold?
Please repeat the question. What was that?
In the severe ptosis, do you do any skin muscle excision just to balance out?
Yes, we have to balance the anterior lamina with our large, whenever there is a redundant skin in those cases, skin muscle, we definitely do this thing, resection, that adjustment of the anterior lamina also. देखो बेटा दोनों आंख खोल के देखो नीचे नीचे देखो थोड़ा हाँ ठीक. So now since on the table adjustment in these cases would generally follow the Burke's rule, that if you have a lesser ptosis and better LPS action, you would leave the lid below the desired height, and if you have a moderate action with a moderate ptosis, you'd leave it exactly where you want to have the lid at post-operatively. And if you have a poor LPS action and a greater amount of ptosis, you would like to leave it higher at about the limbus or so. So the same adjustment, of course, you follow the initial formula, and then if you want to adjust on the table, that is also we follow the general principles of the Burke's rule, 606.
And sir, you have not encountered any problem of, say, like this suturing appears to be little weaker than the horizontal mattress suture which we do. So late post-op droop, again the question remains same. There is no issue about that, no?
Here we are sure exactly where we are going, and the horizontal, the proposed advantage of a horizontal bite was that there might be notching with a vertical bite, but it doesn't happen. We just realized that that was just that is our proposed advantage with the horizontal bite, that if you give vertical bites, you might get a notch due to the bite, but three sutures are more than enough to take care of the entire lid, weight of the lid. Mainly the central suture and the lateral suture. These are the ones that are most important for the correction of the ptosis, and the medial suture is more for the getting the contour right. The lift gets taken care of that, but there is hardly any slippage issue if you take a deep pre-tarsal bite. Rather, I don't prefer doing it through the tarsus, because sometimes you can cause a kink of the tarsus, or a non-uniform depth through the tarsus can cause its own problems. So this is a very simple.
So do we also have to position the sutures the way we do for resection? When we are passing the suture through tarsus? Positioning in the sense that we usually mark the 3 points of fixation to the tarsus based on the anatomy of the based on the limbal landmark of the limbus and the
that we have already passed one in the pupillary this thing axis.
So we follow the same rule here
same,
also.
We didn't really mark it that way, but the stay sutures act as our guide. The stay sutures are actually not only giving you traction, but also acting as a guide for our deeper sutures later on. Okay, so this we are almost through now. We can, if there are any other questions, we can take those right now.
Yes, because
But
I think we are close
here,
to,
yeah, we'll just
yeah, the next live surgery. They're ready and waiting.
So here, sir, you're not passing through the LPS, as I can.
no, yeah. There's another thing that I would emphasize is that here we don't need to pass the lid fold formation bites through the LPS, because the bunching effect is so strong that the good lid fold gets formed naturally. So that is another, and since we haven't disturbed the anatomy of the lid so much, we don't need to pass the lid, the deeper bites through the levator. So, I mean, what else can you ask for? You've got everything here. Because in LPS resection, there are a host of surgeon dependent variables. You have to disinsert, then you have to reinsert, decide where to reinsert, how much to do that. There are so many things which could go wrong. Whereas here, the variables where you could go wrong have reduced considerably.
Yes.
You open the skin orbicularis, identify the epineurosis.
It's
like it.
definitely a much simpler surgery for the beginners compared to the amount of dissection that we have to do in resection and the kind of post-op edema and all that we see. So I think we are close to the end of this session. I would like to.
Can I just add, sorry, can I just add one thing? Dr. Bajaj, that was a really wonderful demonstration. Just wanted to add that point that you put right in the beginning of, infiltration. Even under GA, infiltration is a really good idea. It gives you the tissue planes and decreases the bleeding. So for beginners, I think it's an important point to do the infiltration. And secondly, in the marking, like you said, the center of the lid, actually, I also mark the center of the lid before starting, because sometimes if a little bit of edema, you might actually miss the center, which is, in each person, just a little different. So before starting, just mark the center of the lid on the, of course, your attraction sutures are helping as well, just so that we can, make sure the contour is right.
Thank you so much, ma'am. I think the next team is waiting and we'll have to wind up now. Thank you so much, sir, for that wonderful surgery. And I think Prithvi and Ayush were assisting, sir, and Dr. Parag began the session with the presentation. So thank you to the whole team. Thank you to the panelists. Thank you, everyone.
All right.
Thank you.
Thank you, sir, for
Right,
the
thank you,
wonderful
thank you,
surgery.
Thank you so much.
Wonderful. Excellently performed surgery. And thank you to Dr. Mandeep Bajaj for the surgery. And thanks to all our panelists. Moving on to the next session, which is the DISSEC live surgery, which will be performed by Dr. Radhika Tandon. I would now like to invite our panelists, Dr. Ritu Arora, Dr. Samar Basak, Dr. Uma Sridhar, Dr. M. Vanathi, Dr. Tushar Agarwal, Dr. Rajesh Sinha, Dr. Abhishek Dave, and Dr. Manisha Acharya.
Good morning, everyone. Today we'll be dealing with a 71-year-old female who presented to us with diminution of vision in both eyes from past 3 years, right more than left. The vision was gradual, painless and progressive, associated with pain, redness and watering. Patient had underwent a right eye cataract surgery with PCOL with poor post-op gain of vision 3 years back, and in left eye 1 year back with poor post-op gain of vision. On examination, visual acuity in the right eye was found to be finger counting at half meter with PR accuracy in all quadrants, and in left eye, finger counting at 2 meters with PR accuracy in all quadrants. IOP was 8 mm and in both eyes. The conjunctiva was clear. On corneal examination, there was epithelial microcystic edema with increased stromal thickness, and descemal membrane fold were present. Nasal and temporal superficial vascularization was noted, which was not extending more than 2 mm into the cornea. On left eye corneal examination, it was epithelial microcystic edema with increased stromal thickness, and DM folds were present. AC was formed in lens. In PCL was clear. The clinical photograph, you can see the edema and DM folds. In investigations, there was mild ONH cupping. and white to white ratio is 10.8 in the eye, and ACD is 4.23, and central corneal thickness is 904 microns. Thank you. Now we're moving on to the surgery. Diagnosis is both eye Fuchs endothelial corneal dystrophy with pseudophakic corneal decomposition with secondary glaucoma.
Am I audible? Good morning, everyone. Thank you, Bharat, for the summary. Am I audible?
Yes, yes.
I'm audible. Okay. And is the microscope view visible on in the auditorium? Okay. So as Bharat explained, it's a little challenging case. Corneal thickness was on the higher side, 900. Usually we keep a cutoff of 800 microns, to decide whether to do DSEC or PK. And there's a little bit of stromal scarring as well. So technically, one would have the option of DSEC versus PK in this patient, but with all the benefits of DSEC and with our experience and other people's experience as well, with a successful DSEC, the stromal scarring is known to improve. So we thought we should give the patient the benefit of the technology. Now, the patient's white to white diameter was 10.9 millimeters, so it's a small cornea. And normally one would subtract 3 millimeters to decide the size of the donor button. So 8 was seeming still a very, too large for this size. So 7.75 is what we are planning, what I'm planning. And I made a mark for you. And along this, I'm going to score. I've already put one AC maintainer in place, and I'm using foot switch control for the AC irrigation. So now I'm first going to put in some trypan blue dye to stain the endothelium. I've already put a little bit of pilocarpine to constrict the pupil, and so that sometimes, these patients who've had previous surgery and operated in an outside center, there might be a floppy iris and may not be very stable. So therefore, pilocarpine helps. And now I've injected the trypan blue dye to stain the endothelium. And that is again highlighting the stromal little bit of fibrosis, and we hope that this clears up later on. It does make the surgery more challenging because the visibility is poor, and I've already removed the epithelium, and still the visibility is not that easy. So I'm now going to remove. I've already, and I'm going to demonstrate a superior surgeon's position, and I like to use an oblique position so that I'll be using a pull-through technique so that the nasal bridge doesn't hamper your movements. So I've got my 3.2 incision here and an opposite incision from which I will be pulling the tissue using the Busenglide pull-through technique. So now I'm just going to remove some of this excess trypan blue dye. So I'll have a little contrast of the iris to help me. Then I'm going to go through my side port and score the Descemet's using a reverse Sinskey hook. I'll be using a hemi-rotational movement. Scoring just inside my mark. Again, go once more to make sure that it is properly disinserted. You have to be careful. This eye is moving down a bit. Yeah. You can see that the Descemet's has started separating as a sheet. I want to see why is the eye rotating. Just if you stabilize this AC maintainer, I think it's pushing the eye down a bit. Yeah, thank you. I'm going to start again. I'd like to remove the Descemet's as a sheet because the visibility is poor. It'll be very difficult to remove any residual tracks. So again, going along the semicircle and find an edge and trying to be careful not to scratch or damage the stroma. The Descemet's has started moving. One could use a Descemet stripper, but then I'll have to have a larger side port because the Descemet stripper will not go through this 0.9 millimeter. So if I have a lot of difficulty, then I will use my 3.2 blade to put the Descemet stripper. So I'm just using the Sinskey hook to slowly remove the Descemet's. I'm sure it's not very easily visible to all of you. Maybe I can show you an IOCT in a short while. I use a little movement of the Sinsky to remove it. There's still a little remnant present, and this tissue will be sent for histopathology. Okay, now give me the stripper. So this is why I prefer having a access of both the incisions in case I have to go from another side with a larger opening. Just 3.2 dena dobara and keep the forceps ready. So this is the Desmet stripper. It requires a little larger incision for entering the eye. Okay, give me a MacPherson, please. We'll put on the IOCT and see if there are some tags. I suspect that there's a little bit of a tag here. Usually in Fuchs, the Desmet's is very thick and it comes off in a sheet. This was a little fragmented. It may be because of inflammation from previous surgery. So I have a suspicion that there is a tag here. So I will recheck with forceps. Otherwise, the rest of it, you can see a small tag there also. This is the IOCT demonstrating the, so it's just this area that there is a little bit of residual tags. I'll just reconfirm. I'll put bursts of fluid of DSS to let it flutter DSS to try to identify and confirm if there is a Desmet lying there. You can see the little fluttering movement. So forceps. Thank you.
Good morning, ma'am.
Sensky. Sensky.
Dr. Basak and we are here. Just one question to Dr. Basak, sir. When do you do non-Desmet stripping dissect, sir?
There are only few situations like typically post PK.
It's pitch here, no?
And shade.
It's not
shade,
attached. It's stuck
congenital
here.
hereditary
It's stuck here.
endothelial dystrophy where you cannot have very good stripping of the DM. And in those cases, you may do the end dissect. But regarding the remnant of this little tissue, sometimes it may not be possible to remove.
Normal.
And many people do not have IOCT that
Yes.
in those cases, if you put a little air bubble,
The
you can
visibility is,
see
yes.
the a DM in those areas beautifully, and then you use your.
Sometimes you can see it against
It helps
the,
to take
this
this
thing,
off,
no?
yes, sir.
You can also sometimes put an instrument inside and see against it if the blue tissue is separated or not. I think my bed is clear. So we'll now prepare the donor tissue. Before doing that, I like to demonstrate that you do a dry run. So the donor tissue is going to be in the Busen glide, and this is going to be my forceps. So just before I actually load the tissue, I'll recheck that everything is easy and comfortable. Because sometimes the eye moves and the one second, give me the forceps, 1 second, limbs.
What is your technique of insertion, Dr. Basak?
I use the typical forceps echo and needle techniques. Busen glide I used in few cases.
1 second.
By
let me just
I
check it
didn't
again.
like because of total cumbersome of the procedure that you have to give
me
a
a-
cemented. I never use a cemented in any of my cases, more than 2000 cases. And I'm happy with. And it only takes 11, 12 minutes to complete a study.
Yes.
So those are the reasons.
Do you use an anterior chamber glide?
No,
No,
not
you do a
anterior.
straight push-in.
Straight pushing, little larger.
With a drop of
incision.
viscoelastic on
Yes,
the,
yes.
yes.
Little
okay.
larger incision,
Incision.
that is the key.
Yes. So what's your incision size, which you would normally
Usually
prefer, sir?
5.5 in those cases.
Okay.
5.5.
Yeah.
And
you
sclerocorneal, naturally.
okay. Not clear corneal or
OCT?
limbal. So you do a
gastric
peritomy
medicine
and then
part
go in. Yes.
is taken care.
Yes. And what about your Desmond's scoring size, sir? How do you keep it? Do you go beyond, or would you usually keep it within your
same size.
same size?
For DSEC, it doesn't matter
Yes.
if you are little smaller or larger. Larger, of course, not.
It's fine.
Because
Not preferred,
sometimes
yes.
the peripheral villus keratopathy
Right here.
Yes, sir.
persists for many months and patient may remain symptomatic. And in those cases, you need to give PCL additionally for a few months.
For a longer period of time. That's right. So that's something for beginners which they need to note, that do not score over the region of marking or the size of the graft here. Because if you take out desmoids from the region where your lenticule is not going to be present, then that region you would have persistent corneal edema, especially in the periphery. And that leads to a very symptomatic patient for a long period of time, increases your inflammation as well. And the patient is pretty unhappy, even if your graft is doing well.
So this is what I meant. Always better to check, like
dry
for example,
Yes.
my incision was made earlier. I wasn't able to find it. What I meant to do a dry run first so that we're ready. Okay. So now I'm going to load the graph. So it's a pre-cut tissue, pre-prepared. Bharat, would you like to tell information about the donor tissue? Microscope आगे करना थोड़ा.
Any particular preferences, ma'am, on the donor tissue for endothelial keratoplasty?
Yes, ideally we would like a donor. If we're doing a DSEC with an automated, for the donor preparation, we would like an adequate rim. Ideally, the donor age should be above 20, but we have often prepared donors above 10 as well. And then below 10, one could do a PDEC. And the count should be ideally above 2,500. Tissue should be as fresh as possible, but within the normal limits of the safe cornea. I need the microscope here.
Yes, again, there's one point for beginners that when you're using an automated microkeratome
orderly who had
and
done
you're
it
going to
earlier,
do
no?
your cut for preparation of DSEC tissue, you would like your scleral limb to be adequate enough for it to be mounted on the microkeratome. So I think, sir, with your, I think you do a manual dissection for your DSEC tissue
We
preparation.
have my
So
on demand, patients demand.
Okay, so here you can
Yes.
see the donor tissue. It is has been just don't block my view, please. Yeah. So the donor tissue has been cut using the Moria microkeratome, and 7.75 punch has been made. Nupur will tell you the rest of the details about the donor.
So the donor is a 17-year-old male. The cause of death is hanging. And there are the endothelial count is 2445, so 2,445 cells per mm squared. The death preservation time is 21 hours.
You mustn't block my view because you see the screen blocks my view. Thank you. So when I punch the donor, I like to keep the anterior lamella intact so that the tissue is more stable. This tissue is very thin. It is 75 microns thick. So normally I scoop up the entire tissue along with this and separate it on the platform. But in this case, it being so thin, it may be very difficult. So I'm going to take only the tissue right now. Okay. So it's very, very thin. Separate it all round. Just stabilize the Teflon block. Thank you.
what is the normal thickness, Dr. Basak, you would like to prefer when you're doing your D6?
DSEC, between anywhere between 80 to 150. It is fine. Manually, yes, you can control with experience, but automated, you have now
So if I
preferences.
lift it up,
So
will
you
you be
can
able to
go
pull
deeper.
it? Give me little
And you
heel
may
on.
have thinner tissue like in this case.
Okay.
Heel on.
Thin is always better.
Back to the microscope.
Do you use marking of the tissue with your DSEC lenticules? I think I don't use much of the marking on DSEC lenticule.
No, nowadays my indication of defects
It's
that
much
most
lesser.
of the difficult cases is I do mark.
Okay.
Okay.
And it always helps actually. So particularly in this type of cases where your visibility is
poor,
poor
yes.
and your tissue is thin, you
You're
have
marking, that's one of the particular
AC
indications when a
maintainer,
marking would be. Yes.
you have an AC maintainer inside the anterior chamber. You may not, the assistant or your foot pedal control may not be
I'm going to
right
ask you
at
to
right moment. So the tissue may tumble.
pull out.
So that is the reason I always tell my juniors, yes, use marks, nothing harm in.
So this part you will
Especially
pull
for
out.
Nothing
Okay?
harm.
Yes, for the
But
beginners.
DMAC, yes, you
yes.
should not
They're
use
visible
too much
to
of
you?
marking because
Okay.
alcohol content may kill some cells. But DSEC there is no.
Let's bring
There
it
is
up.
no
This is
harm.
the
Always
stroma.
help.
Okay. So what I'll do is
Especially
I'll
for
align it
beginners,
this way.
and
What
especially
did you
if your
I'll
if
hold
your
it here.
visibility is particularly poor and you have a smaller or a shallower anterior chamber,
Right,
and when if you're not able to make the flipping over of tissue, then
Right
it is
hand, okay.
always safer to mark your tissue.
As you can see, this is an extremely thin tissue.
Yes.
These are the tissues where if you do not have
Yes.
IOCT probably does not help in this kind of thickness.
Okay, now the challenge is going to be when I'm
DMAC.
inserting
Because
it,
you
the
can't see
tissues
the
have a
configuration
tendency
of
to
the
go
scroll, so it
posteriorly.
really does not tell you if the orientation is right.
I may need your help.
That's
to
one
give me the
particular
tissue.
difficulty which beginners will have to anticipate when you're doing an ultra thin DSEC.
Yes,
Yes.
this is ultra
So for beginners, it's better to
less
take
than-
deeper anterior chambers and use pseudophakic eyes in your initial stages and
Just
when
hold
you're
this for
learning
me.
phases before you go
One
on to
second.
do
You
DSEC
give it
and
to me when
phakic
I
eyes
ask
and
for
then
it, okay?
pediatric eyes. So that's a
There it is.
useful tip for people who are started to do DSEC. Yes. Mm.
So this is being very thin tissue, sometimes very difficult to grab. It tends to go back. So I'll have to forward it again. Align it a little further.
Yes, again, now when you're using a pull-in technique, for insertion in DSEC, especially in pediatric eyes and phakic eyes, it's always desirable to constrict your pupil preoperatively and use the iris covers. Always do you insert your instruments under the protection of the iris cover so you do not damage the lens here. And that is a particular tip when you're doing DSEC in phakic eyes for all beginners. So I tend to place my incision as not
Will you hold
exactly
this?
180 degrees
Give this
away,
to me when I
but a
say,
little more towards the or
Lens.
closer to the main incision so that you're over the iris cover all the time.
What's happening is because of the tissue being very thin, it tends to retract into the Busen glide, not able to get a good grip of it. But now I have it, I've rearranged it, pulling it into the eye. Again, it's left. Let it open.
Yes. Yes, ma'am, we can see the tissue is now
Yes,
open.
Yes, 1 second. And I just rotate this thing, bring it this way. It's slightly decentered. I'll put an air bubble. No, air, please.
If you have air.
Yes.
Now this AC maintainer is abutting on the tissue, but I'll put a small air bubble first, making sure I'm deep to the tissue. Since I'm safer here, but this is a bigger incision, so I'm going to go from here. Okay, this.
When would you like to switch off your AC maintainer, ma'am?
It's already been off because I do foot switch control.
Okay.
Once I'm sure that my air bubble is in the proper place, I'll remove the AC maintainer now.
Yes. So
I
that's
do
another
foot switch
particular
control. Yeah.
particular step that beginners will have to pay attention to, that you will know when, if
be
you're using
careful
an
when I
anterior
inject
chamber
the air.
maintainer, you should know to stop the flow as soon as you're, you should coincide both together. When you're leaving your grip on your desec lenticule, your flow should be off. Otherwise, you will have the danger of your tissue being washed out of the eye or being displaced. So again, be careful. And that's when, if you're not using a foot pedal control and if you have an assistant, you would want to prime your assistant beforehand.
Anterior to, it's got folded.
Yes.
Yeah. That air bubble was going anterior to the graft and probably folding because it's extremely thin tissue. And so I'm going to now just put some more air and then I will center the graft. Otherwise, I will use a 26 gauge needle and air and go in with that. I'll first suture this wound. Suture place.
Just
Yes, with reverse Sinski, I can pull it. Yes.
Yes.
Very
A
fast.
rapid tug, yes.
Very
Helps you to
fast,
position it in center.
Then you again
Yes.
play with air.
What is your take on doing peripheral iridectomies in
No,
DSEC, sir?
normally, no.
Yes.
Yeah. Air, please. And suture it in. Yeah.
So for beginners, again, it helps to use a pre-placed suture in your main incision, and you would probably like to
Needle
close
holder.
your main incision wound
Needle
with your
holder first.
suture before you do your manipulations. Yes.
Suture it in. Yeah. Suture. So as you see, when I was trying to pull it through that, the air was leaking out and it was producing the collapse. So I'm going to suture this wound and then center the
You
graft.
can use the side port.
You know what was happening with the side port is but first I'll just suture this because it was becoming very unstable.
This doesn't happen.
Yeah. This is, yes.
Okay, now give me the needle holder. Chetan,
How do you go about sizing of your DSEC tissue, sir?
Sizing depends upon the horizontal
Yeah.
diameter. I
2
always
minutes.
operate from superior head end of the patient, so I prefer the horizontal diameter, and I always say that the
So give me the
working
reverse
area should
Sinski
be
again.
1 millimeter on either
Reverse
side.
Sinski.
Yes.
So 2 millimeter less than the, typically 8 millimeter is the size, but 7.75 or 7.5 sometimes. The corneal diameter in Bengal is little lower, so 8 millimeter is by and large. So 10 millimeter
Reverse
horizontal
Sinski,
is there, so you take 8 millimeter. But some of the
Needle holder
cases
is
you have to
sitting.
deliberately choose the little lower diameter, like eye syndrome, where you should not go and
Closer to the angle, yes.
with the pass area, so you have to be very careful. But again, with
Reversals,
ophthalmic
yes.
eyes, it was
Yes.
so difficult.
Can we have the
because
OCT
you
on
are
once,
having
please?
Do you
14
move
or
with
16
the larger size
millimeter.
tissue, sir, in the ophthalmic eyes?
Yes, yes.
Okay, now give me the needle holder.
It always helps
Wet
to
the cornea.
suture the main port.
I do not suture any time. But
Yes,
reverse
most of the
okay.
time. Yes, but
90% cases I do not. Because sclerocorneal tunnel I make.
yes.
And those are actually self-filling. Side port as usual with 1.5, so it is fine. So that is the
Yes. So you can see that's the tug of the tissue with a reverse Sinski to
Yes,
center
air,
it
please,
on.
air. Only thing is the graft being very thin, no, it's folded up over here. So I have to put air first and then I will
Yes.
unroll it.
That's a particular difficulty if you
Very
use an
thin
ultra
graft.
thin
Yeah.
graft here. So you have
Now
to
it's opened
anticipate
out.
these. Yes.
We check with the OCT. And the other thing is in this case, the visibility was very difficult. That was the trouble. But I think it's all right now. We can see it's nicely centered. I'll give it a few minutes to settle and I'll put a little more air because I can see a little fold here. Right? So this, I will get it to settle down. Yeah, sure. Right, sure. Fine, that's fine. So we're going to flip to the cataract side and come back to show you the final. All I'm going to do is from here, I'll put a little bit more air so that this little folded part of tissue opens out. And otherwise you can see that the air bubble is in place, tissue is well attached. There are a few areas which are got a little bit of fluid, but with some massaging that will clear out. We'll come back after the cataract case.
Thank you very much, ma'am.
Thank you.
Yeah. Thank you, sir, again for
wonderful,
being with
wonderful
us. Thank you, sir.
surgery, Radhika,
Yes.
and
I think it was a
lot
nice
of learning,
demonstration of
nice.
a, yes, of an ultra
Again,
thin
it's folding
segment.
from there.
Tilak.
Every time I do it from there, it's folded.
हाँ आ रही है आवाज आ रही है बोल
So you have to give me a reversal here again.
Excellently performed surgery and very well demonstrated by Dr. Radhika Tandon.
Thank you.
Thank you, Dr.
This is the
Radhika.
trouble,
And
you
thanks
see
to all
here
our
it's folding
panelists, Dr. Ritu Arora, Dr. Samar Basak, Dr. Uma Sridhar, Dr. Vanithi, Dr. Tushar,
No,
Dr.
no,
Rajesh,
because of
Dr.
the graft
Abhishek,
getting
and Dr.
folded, you
Manisha.
know, so I have to
Thank
again
you.
release it.
Moving on to the next session, which is subjected on cataract refractive sessions. The very first session is the flax plus panoptic session, which will be performed by Dr. Jeevan Estetial. I would like to take the honor to invite our esteemed panel for this live surgery session. Dr. Rajendra Prasad, Dr. Alkesh Chaudhary, Dr. Mayank Pandey, Dr. Prafulla Maharana, Dr. Bharti, Dr. Partha Biswas, Dr. Purendra Besan, Dr. Rohit Om Prakash, Dr. Amit Gupta, Dr. Chintan Malhotra, and Dr. Sonu Goyal. AV team, can we have a look at the live OT for the current session?
Very good afternoon to everybody. So starting with our cataract refractive sessions, our first patient is a 51-year-old male. He has no systemic illnesses, had complained of diminution of vision in both the eyes. He's a businessman by occupation. He has right eye immature senile cataract with posterior subcapsular cataract. Angle alpha is 0.310 millimeters and total higher order aberrations was 0.231 microns. Patient does not have any ocular surface abnormalities. So for this patient, we have planned a right eye phaco plus PCIL under topical anesthesia. Alcon panoptics lens of plus 20.5 diopters has been planned for this patient.
Hello.
Yes, sir, we can hear you.
Yeah, good morning. I'm not sure who's there now.
Good morning, sir. Dr. Basak is here and Praful.
Yes, we three are here.
Okay, thank you,
As a
Basak.
panelist. So you are doing a femto-assisted flag.
Yeah, FLAC has been done in this particular case because we have FLAC OT upstairs
I know.
in the 6th floor, so we didn't have a transmission coming from there. So we have just done the flex, and we all know the advantage of flex also. It gives a pre-capsulotomy of 5.2 millimeters my size and fragmentation. Along with that, incision. The device we use is Lensix. It's been there with us for almost 10 years now. And my colleague, Dr. Manpreet Kaur, who has done the flex part upstairs. And the responsibility given to me is to open these incisions which been created by femtosecond laser first. So it has to be dried out first so that you can see the incision marked by the laser. Or if you have a high magnification, which can be done with these off microscope heads-up devices, where you can go to very high magnification without distortion of the image. So you can see the image is very clear now. I'm just going to open this. So this is the opener. Gently open the incision vertically first, then go horizontally as we do for our other case. At this stage, we'll put our viscoelastics to maintain the chamber. Femtosecond sometimes does constrict the pupil if you delay the surgery because he was waiting for 20 minutes. But despite that, pupil is quite okay. We have a very round circular capsular axis, which is so important for all types of lenses, but more so for our trifocal lenses. Again, just a vertical opening and going. How easy it is to open. I think this is one device, Lensix, where corneal incisions are the best amongst all the femtosecond laser devices which are available. So you can see sometimes you miss out the thing, but it's so simple. I'll just hold the, with this instrument itself, then I'll take out this free floating capsulotomy. Just do a nip, hold the capsule, dimple up, I can just pull it out. So this is such a free floating capsulotomy. I'll just wet the cornea because there's a little bit of a floppiness maybe there. So I'm putting an intracameral adrenaline to dilate the pupil further and decrease the floppiness. You can see one bolus under the viscoelastic. That is very important point, under the viscoelastic. Then I'll do a little bit of a hydro dissection because delineation part is missing. You can see the 8 spokes of laser. You can see 1, 2, 3, 4 lasers are there. माफ करते भैया, टेबल मत हिलाओ. Remove the viscoelastic little bit. Then just lift the capsulotomy edge, go underneath, inject the fluid. You'll see the wave now. Gentle injection is what is required. Complete the wave. There's no sub-nuclear bubbles in this. All the bubbles are right in the center. So there's no chance you're going to increase the pressure to the posterior capsule. Just release the fluid as we do for other cases. The nucleus should be free with this injection. You can see quite free. It's a very, very softer type of nucleus. So we might do without the phaco in this particular case. Zero phaco would be desirable in such cases. It's a phaco 10 rakhna. Also, you can put a 0 also. So I put the dispersive viscoelastic first. Now the coercive to push the dispersive towards the endothelium to safeguard. Every cataract surgery would have some sort of an endothelial challenge. So that can be avoided by a soft shell technique, which has been beautifully described by Arsenov. So this is a system, you can make it 0 torsion. So first is, we can just fix the globe with going through the side port incision, then go with the phaco needle. You can see how effectively it is inside. This is 2.2. Just take out the viscoelastic, and a free floating cortex can be taken out. And some of the pieces, like this is already, fragmented pieces. So they make a 200 microns cube. Open dekho beta. So I can just go here, open this chop. So this separates the nucleus. So simply I am doing entire surgery the vacuum. So this is the advantage of a pre-softened nucleus. These blocks can be taken out. Yeah, naak bar mein mat chalao. Each block can be picked up, like I have described for a posterior polar cataract, the hybrid technique. Similar thing can be done here. So these blocks can be simply aspirated easily. And this is the time I might have some phaco energy to take out this thick epicortical cushion which we have made. Normally we keep around 500 to 800 micron of cushion of epicortex, and that is the advantage of customization of the cushion, especially in the difficult cases like a posterior polar cataract. Whenever you have a little bit of this was a case of a posterior subcapsular cataract, very posterior polar type. You can see the all description of BSS. BSS, please. Methyl cellulose. You can see that cortical disc defect, which is normally seen in a posterior polar cataract in this patient also. Methyl cellulose bola na aapko. The problem with the HSF device is, the surgeon has to do everything because the assistant doesn't have sometimes the clear position. I put heel on there, that's making life difficult for me now. So in femtosecond laser, sometimes this cortical aspiration can be difficult. So it's better to do a bimanual aspiration in these cases. So this is a hybrid technique aspiration. So I have detached my aspiration tubing from the phaco handpiece, attached that to a bimanual aspirator. So without removing my handpiece, I'm on to the next step. So that makes, especially difficult cases, you can still maintain the antechamber anatomy or a configuration in a difficult situation like this. Yeah, Basak, you're saying something?
Yeah, this is purposefully you are keeping the handpiece, or you can use both the irrigation aspiration bimanual technique.
That can be done because then you have to come out and change your aspirator. I just want to avoid that one step. So it's very handy in those cases where you can do most of the aspiration with your handpiece, which I'll be showing as other case. In femtosecond, sometimes difficult. I'm just going to leave at that stage, little bit of a cortex. That we can remove after implantation IO also. So before I come out, I'll inject some viscoelastic there.
Is there any specific reason you are taking safeguard again? Posterior capsule might come up and.
Yeah. You saw that we can say a cortical disc defect sign in a cortex. So that suggests it may have been a posterior polar type of cataract. So posterior capsule can be weak in these cases. And we know that if you see the disc defect, the chances of dehiscence is minimal. If you don't see the disc defect of posterior polar cataract, then you have a difficulty.
Right.
So that sign beautifully described by us, written by Dr. Manpreet and Dr. Sridevi. So this is a lens which we talk about, the panoptic trifocal lens, which is actually physiology wise or physics wise a quadrifocal lens, which has been made into trifocal so that you have a best distribution of contrast in all segments, that is distance, near, intermediate, and gives a clarity of intermediate vision at 60 centimeter. And that is the distance we normally desire. And it is the refractive design, which gives pupil independence. The central area is 4.5 millimeter. And whatever cases we have done compared with the other trifocal lenses, it seems to give a very good result in terms of a clarity for distance, near, intermediate. And apart from that, the halos glare, which is so important component of all these intraocular lenses, especially square edge, is minimal with these lenses. And wonderful results we have seen in all type of cases. I'm doing a little bit of anterior capsular removal of cells in the rhexis margin. A little bit of lens tag, like you remove lens, just move the lens here and there. That will decrease the whatever fibers which are attached to the posterior capsule. You can see the central area, which is the actual portion for trifocality, is right into the optical axis. Light में देखते रहना ऐसे. Then sometimes the hydration of a femtosecond incision can be difficult. You do a gentle hydration, especially the cannula should be directed towards the limbus so that you don't hydrate too much to the corneal side. So this is a way where you do a little hydration, then try to increase the pressure from the side port. Immediately chamber will form and also oppose the lips of the femtosecond incision. Many people leave this incision without hydration also, but in all scenario, I like to really hydrate the femtosecond incision also. The lens is effectively placed in the bag, and just to see if the lens has no tilt, we'll just see the femtosecond laser. We'll just do a OCT and see if the lens is clearly positioned right in the middle. Because you require an assistant to do it fast from the, because if I do it, the focus will change.
So do you give intracameral moxie?
I'm going to do that.
In your all cases?
Yeah, yeah. I'll just show the incision, which is you can see here. So these are a problem with the modern devices, difficult to be handled by a surgeon himself. So hydrate the wound little bit with the Vigamox, and then go inside, tap the lens and inject little bit there. So this will get into the bag, and then increase the pressure at that time. I'll just do a little bit of hydration of main wound, and that increase the pressure. The most important thing to realize here, the 3 dots of a coaxial light should be coinciding with the centermost ring of a trifocal lens. So this ends the surgery. If you have any other question before we shift to next case.
Thank you, sir, for showing us another textbook kind of surgery. So there are a few questions here. First of all, what is the advantage of using a 3D heads-up surgery? Secondly, since with flags you can modify your rhexis size, is there a difference in rhexis size when you're planning a multifocal IOL vis-a-vis a simple monofocal IOL?
Okay, I'll answer the second question first. In terms of sizing of rhexis, it has to be made in such a manner where the optics of lens is covered all around 360 degrees, at least if not by 0.3 to 0.5 millimeter. So that will give a good effective lens position and good centration, not only on the table, for a long term also. All these multifocal lenses or aspheric lenses has to remain in the center for a long duration when the capsular bag is getting phimosed. So that is very important. If we do a rexis smaller, the chances of phimosis is much more. As far as the difference between the monofocal and multifocal concern, the ideal size is almost similar, because if you look into multifocal lenses, it is only those lenses which are pupil dependent. There things may be different, because if you make a axis too small, that's going to prevent the peripheral rings coming to action. But these lenses, it hardly matters. The adequate axis will be 5 millimeter in these cases. As far as headset device is concerned, it has the advantage of two or three important things. Apart from being off microscope ocular so that your neck doesn't get extended or flexed, your position may be much more comfortable. But other way around, my working axis also changes. So that is a difficulty with the off axis working. It gives a very good magnification and clarity also. And because you are seeing through the polarized glasses, so you see better. Maybe it decreases the light also. If I remove my glasses, you can see better. Third is, the patient has a sensitivity to the light. You can work with a very minimal light also. So that's a major advantage. And these devices are attached to all the advantage of these microscopes, which is Callisto and OCTs.
Thank you very much, sir.
We are we are shifting to a DSEC to show the end of surgery.
Yes, sir.
Yes, ma'am, we can see
Can we
you.
have the microscopic view?
Yes. So are you able to hear me?
Yes,
Yes,
very
Yeah,
ma'am.
well.
so fortunately, the graft is now centered and it's stable, it's attached. I've put a BCL because I had removed the epithelium, and I've going to give a subconch, and patient has already had 10 minutes lying time. So then the patient will be shifted on a trolley. And
We
we're
have the
still
IOCT view,
supine
ma'am.
position. Yes, IOCT. So being a very thin graft, there are some wrinkles, which, the graft as such is well attached, but there are these few wrinkles. And I'm not going to trouble myself over them because I think they'll settle down. The graft being very thin, the moment I put too much air, it folds up on itself. I'm sure this patient will be fine post-op. As you can see, it's like there are the few very fine gaps which should absorb.
I think this is
Yes.
primarily due to the irregularity of the posterior surface of the host itself.
Yes, exactly.
So-
Because the host has a bit of scarring, and so therefore it's not smooth, as you can see. So it's better not to manipulate too much at this stage, and patient should be okay post-op.
So will you do the BSS AR exchange at this point of time?
No, I don't do it at this point,
So-
sir.
And you have not
Yes.
done any PI in this case?
No, I haven't done a PI,
So-
and the patient is
so
pseudophakic.
You
So-
have to be very careful
Yes,
that there
so
is
in
a
the
chance
post-op
of
period, we'll
the
recheck
bloody
again
block.
after an hour or two, and if necessary, we'll burp.
You will barb
Yeah.
from the side
Yes,
port
from
or
the
use
side
a
port.
30 gauge needle or
No, side
maybe
port.
31 gauge needle
From the side port.
from the side port.
Yes.
So there is a question there. So
Yes.
if you in a dissect lenticle, if you burp some amount of air from the side port,
Yes.
you have to be very careful that you should not hit the, if you see the dissect that there are two rings, the outer ring is touching the internal lip of the
Yeah, you
side
see,
port.
this particular patient, we were just thinking in
So what
retrospect
will
of
you use for
7.5.
the,
would
what
have been.
instrument you will use for barping from the side ports?
So one would use a needle itself, because you see here, there's one area over here that it is free. As such, the patient's cornea was
That area
very
is
small.
clear,
So
yeah.
7.7. So this area is the only one which is safe. Everywhere else it is abutting. So from this side.
From that side, that is
Yeah.
very important. If you hit the edge,
the-
graft
yes.
edge,
Yes.
then
Yes.
again there will be problem. And
Quite right.
probably you cannot control barping sometimes. So what I used to do in this kind of difficult cases, I use a 31.5 gauge needle. It is available. take out the plunger. I go from the limbus, any places where the area is more, I just go in, come out.
Right.
Very short.
Right.
Go in and come out, you will see that little amount of air was what when it is controlled. So we then see there is a ream of fluid, and also do you have given any Medriatic in this patient at this point?
No, haven't given any.
So I
Medriatic.
also give Medriatic in this point because I do not know that probably even during shifting of the patient from OR table to indoor bed, then sometimes that air go posteriorly. So if you make the people dilated, say 6 millimeter like that, then chances of pupillary block will be much lower. Anyway, thank you very
Okay,
much.
thank you so much. Thank you.
Thank you very much,
Okay.
ma'am. It was indeed a very difficult case, and you
Quite
really did a
difficult.
great job. Thank you,
Yes,
ma'am.
thank you.
Very nice.
Thank you, ma'am.
surgery.
Yeah.
Can we have the details of our next case?
Our next patient is a 42-year-old male who is a driver by occupation. He has both eye immature senile cataract with nucleus clausus grade 2 with posterior subcapsular cataract. We are doing right phaco and planned a Clarion IOL.
Big view. Is there somebody there?
Yes, sir. Yes, sir. We could see the microscopic view.
Yes, sir, we can see you.
Okay. Thank you, Vanati. Let's start. I've already made an incision, 2.2 here and 2 side ports. I'm injecting 1% sodium hyaluronate to make space in anterior chamber. This gives a clarity as well as the space maintenance and flattening of anterior capsule for doing a nice capsular access. So this is a monofocal lens of newest, latest hydrophobic material, which is clear. That's why it is named Clarion. I do a side port access in all these cases. I'll be making around 5 millimeter access, 4.5 millimeter. First is the radial cut. Then you have to lift the flap. You can see a flap is lifted down. Once you have this flap and this cut here, they can make a rotation now. You can see very nicely. You can rotate and you can size as accordingly desired. You can see I'll just increase the magnification so that you can see clearly. And gentle rotation and be towards the the tearing edge of the flap. Rotate as you reach the paracentral area, then keep rotating. You see, again now rotate very clearly. So this is the area where might go to periphery. Just make sure your flap is flat. No viscoelastic should leak. Gently complete from a periphery to center. So this is a 5 millimeter axis center. And you will be difficult to see where exactly I started and where I finished my axis.
Perfect rexis, sir.
Yeah.
As good as that flax platform, sir.
So any particular tips for the beginners, how they have to place their side port angulation?
Yeah, so that is always now, this is my main incision. This is my second incision limbs. So this is my the axis of my working. So if this is my second hand axis of working, so this should be my side port here. So that my second instrument goes, in a very comfortable direction. That is very important. And this is my comfortable axis. So which is around from, if this is 180 degree, this is around 30 degree away. And this is almost 90 degree away. So this distance will give you enough access between two instruments so that you don't have a difficulty in chopping and manipulation. If you are nearer to the main incision, your second incision, then things become very difficult in separation and all. So that part you have to look into and make sure your incisions are around 0.5 millimeter. The side port doesn't go too long. Again, makes life very difficult. Same thing for main incision also. It should be around normally 0.75 or 1 millimeter, not more beyond that area. And my incision slightly posterior limbus. I'll do a now hydro procedure. So first is a hydro dissection. Just I don't have enough fluid, sorry. Then OCT वाला बंदा कहाँ गया? Today my OCT is not working, unfortunately, because it's the Alcon session. So I think Jai's people don't want my OCT to work. You can see the capsular edge is visible in the OCT. Can you see, Basak? Yes. You can see very nice visibility of our excess edge. So I'll just go underneath. Can you go focus to the posterior capsule, please? I'm just showing the hydro procedures. So you'll see the fluid wave here as well as in the OCT also. So gently I'm injecting the fluid. You can see the space. Beautiful space is created because of excess, and the fluid has leaked out also. I'll just take out the fluid from all around. So this is very important point what yesterday Dr. Ronald Yu was showing, which we describe in various videos and papers also. This is the delineation. You can see a nice delineation happening. Multiple delineation codes have come up in this, which is going to make your surgery simpler and easier. And you can decompass the delineated area also, like this, so that this core will move when you rotate the nucleus. So you can strengthen your hydro procedure again, decompress, keep injecting. So this is a relatively softer nucleus. Again, I could have done with the 0 phaco also, but I like to do a little faster. So maybe we can work with a 30 ozil amplitude. So we talk about stroke length, that is for a longitudinal phaco. As far as torsional is concerned, we talk about amplitude. So you can have 100% amplitude to 0%. The higher the amplitude, your torsional movement is going to be much more. 30 karna, yeah. So my sister telling me that it's 10 to 30. I think it's visible in the panel also. So this is the Centurion phaco system. I think within next few months we'll acquire the newer Centurion model. Again, I'll just take out I'll remove the OCT here because the view will be disrupted. The cortex has to be taken off first. Now you can, I'll see how soft it is. So just take out the central area. So many people do a chip and flip. I'll just make a peripheral separation. So the subsequent taking out the pieces will be easier. So this is just vacuum separation. Now I'll run little phaco. The entire thing can be flipped. So this is a trick on a soft catheter because sometimes people do feel a lot of difficulty in removing soft nucleus also. Now I have 2 layers of epicortical cushion. So I'll remove this epicortex. You can see. Hold it peripherally, just pull it. So this will give fluid wave going through the cushion, and subsequent removal will be easier. You can see here now. So you should allow fluid wave to go into the plane. Now you have a cortex only. So I remove cortex one by one. This is a lens I'll load myself. Huh? So just go hold the cortex. This is possible because we have done a good hydro dissection. And remaining part can be taken away with the, I showed that with bimanual also, the hybrid technique. So I have little bit left that I can take out with the hybrid technique also. The chamber will be maintained and removing my, irrigation tubing, aspiration tubing, sorry. The system will change, attach it to the aspiration handpiece, the bimanual handpiece like this. Then I go underneath, take out this. So this effectively decreases your one step. You want to save around 1 minute, and you will decrease one, forward bulge of a vitreous face. So maybe I'm not sure if that decreases the, the vitreous related problems like especially floaters, PVD. So you can do a little bit of polishing with this. And this is helpful to polish the anterior capsule, subincisional, which is typical with the coaxial one. Okay, now slowly I'll come out, inject the Helon, that is 1% sodium hyaluronate. Nowadays, all 1% devices are, prepared with a bacteria. They are not related to animal rooster comb now. And put a little bit of viscoelastic, that is methyl cellulose, over the cornea. So this maintains the epithelial integrity, also gives clarity also. Now to show how we play with the Clarent device. So this is a lens. You can see Clarent autonomy. So this is a carbon dioxide gas related thing. This is the plunger. And this is the area of lens which will be inside here. So through this opening, I have to inject the dispersive viscoelastic. Normally they have this coat. I'll inject this coat from this till the edge. You can see this coat going now. Reach up to the IOL cartridge edge. So that ends. At this stage, then I'll remove the cartridge. Just lift a little bit and pull it. It comes out. You can see lens there now. I'll press this, which is the plunger. And you'll hear a sound also. So one sound is there, I'll press, and lens will be injected to the up to the area which is required. So this is the area. I'll leave it here. So that now I can inject inside. It's very, very simple and effective. And yesterday I talked about our study in India, which was so effective. Many people did realize that it is a very, very simple device to be used. So it goes with the wound assisted. Can you give me Sinsky, sister? So I'll just fix my glove, engage this to the wound area like this. थोड़ा हिलॉन देना, कम है हिलॉन. This should have been delivered within 1 minute, so I'm slightly delayed. So it has to be done fast because the carbon dioxide gas might go out. I'm a little hasty now. You can see it goes automatically. How beautifully it has gone inside. Then rotate your hand and the haptic will come out. So this is simple and least traumatic to the incision area, and lens goes beautifully inside. So this is opening inside the lens. Any questions regarding this intraocular lens, Dr. Basak and Vanati?
I am one of the investigator of the same study.
Yeah, I know
We have
that.
I have used around 24 eyes, and the results are also very good.
तभी मैंने आपसे पूछा, आप बता पाओगे ना?
But the delivery system is unique.
Yeah.
Unique.
Would this cause a carbon dioxide related problem in the atmosphere?
Yeah, I am only worried about it will cause more carbon footprint.
If you use that number which we are using for our other lenses, IQ and all, maybe my sister might faint, After 40 cases, they might faint with the CO2. But the result we have seen, Dr. Basak agrees also. We didn't have a cases with the PCO. We didn't have a cases with the lens glistening. And more importantly, no patient had glare and halos. And visual acuity was fantastic, despite we had a one diopter cylinder consideration in these cases. Light me dekho beta.
1 year follow-up, no glistening.
Yeah. So you can see here now, as the Praful was asking, so I have 0.3, 0.5 millimeter coverage of lens all around. So this is the ideal position. And all my other lenses, IQ lenses, I put horizontal, 0, 180 degree. Because there we didn't have the square in the optic haptic junction. And once you don't have a square edge, you're going to have at least photoptic symptoms. So my all IQ patients never had this problem. But this lens has a precision edge design, which is 360 degree edge. So they should have had, but in our series, we didn't have any patient complaining that. So beautiful lens, beautiful new material. Hope that Alcon comes out all lenses in this platform, BBT and their trifocal lens, which I used in a previous case. And will not see the patient with a surface haze, which used to come in earlier generation lenses. In fact, some of my residents and fellows across the country would have diagnosed these cases of surface haze like a opaque lens. So it's only the surface, like देखो. And Basak has demonstrated those cases almost 15 years back. I remember the discussion with you, almost 2006, 7, 8, I think. And I have a series of cases. We are going to publish that also, where we have looked into a visual quality in terms of MTF and Stultz ratio in these cases. And most cases don't have too much of a deterioration of visual acuity. Then sister, Vega mouse intra-camera. So at this stage, I have to just tuck the lens in because you can see the rexis. If you have lens getting captured like in the rexis, that means your rexis size is good. If your lens comes out of the rexis, that means your rexis is too large. If it doesn't get into this stage, that means your rexis is too small. So this is one of the best rexis orientation for any lens which can be. So I'll just tuck this in. Now it will get centered. Thank you for seeing these Alcon session. Thank you very much. I'd like to thank Alcon people also for providing the support.
Thank you, sir, for the excellent demonstration of this new inserter and the lens.
Okay, now shifting it to the other OT, where we're going to show the next session, which is the Hoya session. Professor Namrata Sharma will be demonstrating their new injector system of Hoya.
Can we have the
Hoya, thank you, beta. You did very well. Surgery बहुत अच्छा हो गया तुम्हारा.
So we are making the two side ports.
On your stuff.
68-year-old female patient, she's a housemaker complaining of painless progressive diminution of vision for last 1 year. Grade of cataract in left eye is nuclear sclerosis 2 with PSC. We have planned for phacoemulsification with Hoya Nanex multi-cert IOL under topical anesthesia.
So good afternoon, everybody.
Good afternoon, ma'am.
Can you see the microscope view?
Yes, we are able to see the microscopic view.
So I think we are making the two side ports, just like you do always. And then the main wound. So you can see the configuration of the main wound on the intraopacity microscope also. Air. Although you can do this without staining, but I'm just demonstrating that you can even. Yeah. Okay. So the pupil is not dilated, you can put phenocane also. Otherwise also phenocane helps in the sense that it give you some kind of anesthesia, so the patient becomes a lot more cooperative. So you can make out the configuration of the wound which is stained by the trypan blue dye and otherwise also. Helon. DSS. Viscoelastic Helon. So can you show the configuration of the lens, please, on the IOCT, just to show what kind of nuclear sclerosis it is? Then this is a 26 gauge needle which is being used to initiate the capsulorhexis. क्या हो गया?
On the lens.
So you make this first flap, which is initiated. I like to release it a little bit from this side also. And just as you are taking it radially, just come to the edge every time, as has been classically taught. You gather here so you can just see through the gathers by taking them away onto one side. And then finish outside. Now, this is the BSS which is there. So always, whenever you're putting any instrument, it is good to always, see that it is not blocked. And then depress the scleral rib so that your viscoelastic comes out, and so does your capsular flap. Is it centered? Okay. And then following this through the rim of the capsule, what happened? थोड़ा सा अमोघ ऐसे पकड़ लो. And then now we are just going to do the hydrodissection. You can see that the hydrodissection fluid wave has gone this side as well as on the other side. And subsequently we will do hydrodelineation and move the nucleus onto one side as we do multiple hydrodelineations. Again, this is a soft cataract. Now always put whenever you are going, whenever you are going with your phaco probe, always put viscoelastic. And again, like I said before, whenever you are putting viscoelastic, one is just take out some so that it is not blocked, and also hold it like this always so that it doesn't come out as you are pushing it. And this is again the Centurion machine which is being used here from Alcon with extremely good fluidics. Chopper. So just stabilize this with on this side. Little bit of cortex is there. एक मिनट थोड़ा सा chin ऊपर करना. I think it is not centered, but slightly हाँ धीरे से बस. Okay. And towards me, please. Towards me slightly. Yes. This microscope thing is again not moving, huh? It is not focusing.
No.
So you just have to chop now. The focus is not moving of the microscope. Huh? No, this is moving. No, this is not moving. The focus part is not moving. Anyway. So we are now just chopping these pieces. The focus is not moving. Can just somebody check? The foot pedal focus. Fine focus is not moving. So we've already chopped it actually. Can just somebody check the foot pedal, please?
This is an important lesson for the
So
audience.
I think all these pieces have been chopped. Is taraf karo zara no more. Can you just slightly?
We could see, ma'am.
And can you do an intraopacity microscope to see how it has chopped? Can you change the foot pedal if there is a problem with that? No, it is not working. See, this is working, but the other side is not working. This side is not working. Can you center it, Amo, please? Let's finish it. Don't move the microscope, please. Somebody is moving the microscope. So again, you have to chop these into little pieces. So can you center it towards me, Amo? So actually, this doesn't take time. It's not the foot pedal is not moving. Are they changing it? So this is the epinucleus which is trying to come. We can just take it there. Just 1 second. Just 1 second. Let me come up. So they are just changing the foot pedal because the foot pedal, this thing is not working. इस तरफ करना. This is also not working. No, this is also not working. Anyway, I'll finish it off. Just give me. So bit of epinucleus is also coming, and so is the nucleus. Can you move it towards me, Amo, please? Can you put it on epinucleus, please, now? Now, it's always wise to. Can I have? No, it's okay. Sinsky? Sir, change the instrument to Sinsky now because the bag is quite empty. Can you show the IOCT now, please? This taraf, this taraf, this taraf, this taraf. Viscoelastic. So again, you put some viscoelastic after you've done the nuclear emulsification, so that the PC which is trying to bulge down, you can see on the IOCT. I don't know whether it is focused or not. For you all, PC just moves back. And I like to use coaxial, and again, I think it is faster. This is what, we've learned our surgeries on. You just aspirate the bubble a little bit. And it is only the interior leaflets which one should be pulling and not the posterior ones, even though one is, tempted to pull the posterior ones, and like a handkerchief, the cortex gets aspirated. So this 12 o'clock has also come out. Viscoelastic, please. Elon. उधर सामने 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 देखेंगे जी. पूरा तो है नहीं, दूसरा वाला दो full. So now you have to fill the bag and you have to fill the bag again. Always spill some out to see that nothing is blocked. Fill the bag in such a way that the margins of the capsulorhexis will become prominent and then they'll kind of blur, which means that the bag is completely filled up. So you can see that the margins are, will become blurred, after you have filled it up. And now we have the lens. Sister, I'll do it. Have you opened it? Okay. So the first thing that is done for this is that it has got 3 steps. I think we'll just to show this, we'll take it a little up. So this is step number 1. So step number 1, is it visible there, Praful?
Yes, ma'am.
No, give me a thicker cannula. So step number 1 is this. It's written 1
It's a
here.
little
So
bit too bright.
There's
it
a
is too
glare on your
bright.
device, ma'am.
It is too bright. So put it on retro. This will become okay. Put it on retro. Put it on retro. No, this side. Towards me is retro. Yes. So is it visible now? No.
No, ma'am.
It's got worse actually.
Okay. थोड़ा सा इसको दूसरे side कर. No.
Assistant, keep it diffuse only, but reduce the illumination.
Reduce the illumination.
Amok.
Amok, reduce the illumination. Is it okay now?
Yeah, it's better now, ma'am.
It's better now, but I don't see anything.
Yeah.
Huh? I don't see.
Okay.
Can you increase it slightly? Yes, yes. So step number 1, it's written 1 here. You can see 1 is written here. So what you do is you have to put.
I think she has to decrease the magnification.
As you are seeing Dr. Namaskar using this direct device.
I don't want
Praful, can you hear me?
Yes, sir.
तुम लोग किसी और ही दुनिया में खोए हो? You can see this new device which has combined both the aspects of screw device as well as the plunger device. So whichever way surgeon is comfortable, you have both the options. So this one device gives advantage of both ways to handle these. One of the best preloaded device I have used in my life. I've been using Hoya injectors for last 4 or 5 years now. I think I would have a largest experience right from the ISET days to Vivinex days. And this new concept, I've been a part of initial discussion in the Hoya team, has given us a new access of surgeon to be comfortable. Once you are comfortable, your incision is going to be comfortable. You're going to have a least stress in the incision. And this lens can be injected so beautifully because it has a very beautiful inner coating where the lens gets automatically inside the antechamber with a little bit of pressure. So it has an advantage of both ways. And other important thing is the IOL which you're going to use in this has the surface modification of posterior side with ozone treatment. And that is going to really decrease the posterior capsular opacification in a long run. The study we are now going to complete 2-year outcomes of Vivinex does tell that PCO requiring YAG laser capsulotomy is very minimal. In fact, we have not done a single YAG capsulotomy till date. So that is what my experience, and it's been wonderful. I thank Hoya for getting to RP Center and assisting these centers IOL inventory. I'll now thank you, Namrata, to proceed. Thank you. Sorry to disrupt you.
No, it's perfectly all right, sir. So now we are just putting the IOL.
जैसे चेंज करा दो मेरा कहाँ गया? Sorry.
I think the best part of this injector is that this goes through 1.8. The outer part of this is 1.62. This elastic, please. Elon.
Also, the unfolding part is very smooth.
Unfolding part is very smooth, and it goes through less than 1.8. Since limbs.
And you really don't have to struggle. There are no problems which could be there related to the loading of the lens. You know, there are no scratches, there are no marks. The haptics are absolutely fine. There is no microbial contamination of the anterior chamber because you're not touching any part of the ocular surface. So this is we've done a study actually wherein we've compared and seen that what is the distance on an intraoppository microscope, the distance between the posterior part of the lens and the posterior capsule. Can you just show that, Chetan? And this is a published study. So what happens is as soon as the viscoelastic is there, there'll be some distance between the posterior part of the IOL and the posterior capsule. And the beauty of this lens is that the posterior part of the lens is treated with ozone, and so there is hardly any PCO. So can you, have you shown the gap between the two? Has it been focused? And then there is a scale by which we measure what is the gap which is present between the posterior part of the capsule and the anterior part of the posterior capsule and the posterior part of the IOL. How much is it? Then subsequently what we do is that how much is it? So it is about 500 microns, and subsequently now we have to aspirate the viscoelastic. And because we had done it under the we had done it under Helon, so the Helon will come out very easily and very quickly. There will be no problem with that. You can move the lens a little bit from one side to the other. So there is that little cortex piece on one side which was there. So I've just pushed the lens a little bit and taken that out. And now we are just removing the viscoelastic completely. Now, once the viscoelastic is completely comes out, then what we do is again measure this distance between the lens and the capsule. So now the entire viscoelastic is out. BSS. And we have to hydrate the wounds now. Is taraf karo, please, Amol. So we'll hydrate the wounds. Can you show the hydration on the intraoppository microscope, please? Is taraf karo, meri taraf, please. The patient is moving away from me. So as you hydrate these wounds, you can actually see on the intraoppository microscope the spindle which forms of hydration. And if there are any wound site DMDs, even those you can make out. So this we've hydrated completely. And then in the end, we again measure the distance which is there between the posterior part of the lens as well as the anterior part of the posterior capsule. इधर सामने देखेंगे जी, हाँ. So again we'll measure this. What is the distance? BSS. So it is now 151, which means that all the viscoelastic is out. So, okay, thank you very much for your attention. And I think there is another case which is waiting there on the side.
Next, we have a 63-year-old male who is a retired officer. He has right eye pseudophakia and left eye IMSC NS3. We're planning a left eye Zeiss 80 trifocal lens.
Can you see the ocular view?
Yes,
Yes,
now
sir.
we can see.
Okay, as you heard, he's my young friend, very cooperative, and he has grade 3-4 nuclear sclerosis, clear cornea, and good dilatation. I'm injecting viscoelastic inside to maintain the anterior chamber. And in this particular case, we are going to use another trifocal, that is Zeiss trifocal. This is a non-toric surgery. And advantage of Zeiss trifocal lens is it is the full optics design. refractive diffractive design again, and not dependent, non-pupil dependent, which is the major advantage.
You're at home. Okay, sir. Okay, no problem. I thought I'm being
The
called.
same step as you saw in the previous case, my Rex is going to be similar. Once I have a flap, things is simpler. Never use a very cohesive viscoelastic like a Helon GB. That will make your axis making very difficult because your flap rotation becomes very tough. If I have to do a soft shell technique at this stage, then I prefer a triple soft shell technique so that I have a fluid space for a manipulation of this flap in a desired manner. I can put this flap down so that I can reach up to the peripheral area and make sure that our axis size is controlled and gently rotate. What's the hurry in this stage? You can gently rotate and make sure you improve your sizing as per the requirement. I can just go rotate this. I want to make it a little bigger. I'll go again. So it's a sort of a spiraling technique to manage your size as per the requirement. So I'm making around 4.5 millimeter axis here. So it's done. So if needed, we can just modify the axis subsequently also. Always take out a viscoelastic. Never do a hydro procedure with viscoelastic on. And always do hydro procedure from the main port. There are many people, they do all these procedure of axis making from the side port without making the main port. In that scenario, before you attempt to do a hydro procedure, make sure you are incision on. So my flap is absolutely clear out. Now I'll do a hydro procedure. Go in, inject. This is a cortical cleaving hydrodissection. A good wave, that is one. Decrease in the glow, second. Little upward bulge of a lens diaphragm, 3. Then we release the space of the fluid. Once also all the release have come, the lens should rotate freely. So these are 4 important significant signs of a completion of hydrodissection. Now we'll go for hydrodelineation if possible. I'll try because this is a hard nucleus. Large. You can see the ring is too large. Larger the ring, harder the nucleus, bigger the nucleus. Darker is the color, harder is the nucleus. Softer, you have multiple gold rings. So this has grade 3, grade 4. Again, soft shell technique, dispersive viscoelastic first. In the central area, which is the area of concern for us. Then inject cohesive underneath that. So this we do for every case, and that safeguards few important endothelial cells. So I have parameters now, which is we might increase to 60 ozil amplitude here, so that we can do a fast central small trench. Okay, that makes life very simple. If you do a central trench, I can do direct chop also. But central trench gives you a very nice separation of a central core and makes things very simple. So I already have this core now. I'll decrease the amplitude now to 50 at this stage. So, and hold this area, then go little periphery, come chop it. You can see a full separation. Rotate the nucleus. Go to other side, then chop it. With a simple manipulation, see my only left hand will be mobile much more than the right hand, which is the chopper. Again, chop it and horizontally separate it. Sort of vertical chop and horizontal separation. Rotate, do a multiple chops. Make sure they are free from the innermost junction, that is the backbone. And always eat in the middle. So once if you eat the chunk in the middle, that is the phaco, central area, which is far away from the endothelium, as well as away from the posterior capsule, because as such posterior capsule will be safeguarded by the epicortical cushion. So we have to make sure that we don't disrupt the epicortical cushion in all cases till the end of our last piece. Each piece is taken out in the middle and they are rotated. I'll rotate the piece again. See the gentle rotation. Always get the piece to your simpler axis so that you cause least stress to the wound area. I'll just get the piece to the center, make it smaller, then eat it. In the middle, in the back, you can see I'm inside the back here. So now I have a cushion. You saw in the previous cases, I'll just take out a cushion now. Only vacuum is on, you can see the panel. And try to pull from the side so that it is free from the capsular bag. They'll automatically come because they have been freed by the previous your step of hydro dissection and delineation. So each step takes you to the next step in a safety manner. So every step has to be done in a manner which safeguards the next step. And last will be placing the IOL, and you have to maintain the integrity of posterior capsule and the anterior axis both. Because you have done a good nucleotomy, but if you can't save the posterior capsule, then what's the point? So I'll again, because this I want to show the routine aspiration of a cortex instead of doing a hybrid, because many people may not be comfortable with hybrid one. I'll choose the routine coaxial aspiration to show the people how it is done. So little bit of a maintained anterior chamber. Make sure you run your handpiece outside. No bubbles should go inside, because otherwise you will be, just aspirating the bubble only. See how much time was delayed when I shifted to a coaxial aspiration. That I could have avoided if I used the hybrid technique. So people should learn for hybrid. So this is the opening here. I'll go opening there and hold this cortical thing, then pull towards the center. Never try to eat in the periphery. Now come this, rotate your hand, and not hand, all your interosseous muscles should be working at this stage. Not like this. The tip should be visible always to your side. Again, I'll hold it and rotate up. Again, go there, hold it, pull it, rotate. Hold it, pull it, rotate. And this will also allow, this is because staining because of dispersive viscoelastic, that is this coat. So this coat also stains the sub anterior capsular epithelial cells. So that also gets stained. So you have a nice way to stain this. That's going to clean the entire anterior capsule very, very nicely. The only problem here is difficult to reach the sub-incisional area. So that would be done by the bimanual apparatus only. So we are going to inject the next trifocal lens. The material is hydrophilic, which is coated hydrophobic. It's the newer generation hydrophilic lenses. The PCO rate is very minimal, and the long-term results in our hand has been fantastic with these lenses. Patients are very, very happy with these trifocal lenses. And Zeiss has been there for a long, long time, and their results have been fantastic. Right across whatever lenses they have come out, it may be heparin surface modified lenses or these trifocal newer generation lenses. The advantage also is they have a highest range of cylindrical lenses possible. This is my sister has loaded this lens beautifully. I'll go. It is again a wound assisted insertion. Can you give me the sensitivity, please? So this is a right way to stabilize your, you can say, eye. Then you have an injector in the wound. Then slowly inject this lens, which will go inside very nicely. Don't have to push too much. Very slowly you can go gently, I'm trying to push very, very slowly, so I'm not sure The lens is stuck, I think. Sister. Sometimes, if you don't see the trailing edge, lens can get stuck. That is what has happened in this. I'll have to do myself now. You can see this has happened again. What do you see, Dr. Basak?
So now the time is. So this is the Zeiss, no? Zeiss trifocal.
Yeah. So should have done under the microscope. Sister doesn't have a microscopic eyes.
So that is the problem. This is hydrophobic, no?
This is hydrophilic hydrophobic combination.
Combination, right?
So I think live surgery, this should be shown how to manage this lens now. So I have a long vanas. I have coated the surface with viscose. That means both anterior and posterior. So
this is simple angular venous, or you have a oil cutter?
This is a cutter. Sorry, banas.
Simple angular venous.
Yeah.
But sometimes it doesn't cut because it is not so stout.
Because this is a slippery lens now.
That's what I'm.
Unlike hydrophobic lenses, so this becomes a slippery lens. And maybe the incision has to be enlarged so that I can, manage this lens. I'm trying to hold the lens from other side so that I can reach the, central area.
We use a different instrument where in left hand we just fix the lens optic, and right hand it is a cutter, basically very stout angular, I mean vertical type of blade. There are many models are there, and you can just like nutcracker in old age, those kind of time.
Okay. I think few days back only I had these people coming to me, MST people.
MST, yes.
They were saying, please take this cutter.
MST, yes, that is from
I
MST.
said, I don't.
Right, MST.
Yeah, I don't need a cutter. Today it would have been a good way to demonstrate. The 2.2 then, 2.8.
Only important is you have to use the very good dispersive viscoelastic. Viscose probably the ideal, and because it needs maybe 1 or 2 syringes you have to fill so that there should not be any damage to the posterior capsule as well as
yeah. So people should learn like at this stage also, don't get too hassled because this is a simple thing to handle. Once you hold the lens from either side, and cut it also very easily. It's important to have a support from the other side also.
Yes.
Like you're supporting from their side. Now I have 2 pieces. So this has to be taken out with the bimanual technique. Hold this piece first and use the holding force. So 1 piece will come out easily.
Very nice demonstration.
And go with the second hand. Take this piece again down. So you can see the edge. You can see how thick the lens is in the center.
Yes.
So it becomes really difficult to cut. You can see that, Periphery is good.
So this is, what is the diopter of this particular lens?
This was 19.5 diopters. So it's okay. I think around 20 diopter is the standard power. Okay, it has come out.
Very nice.
Now I'll do myself, and I'll have an instructor with me, because you can't have Manpreet everywhere, no? Elon, please. I'll fill the bag again. Okay. So you do have these challenges. As Dr. Basak was saying, it's very important to safeguard PC and endothelium. And we as a corneal surgeon, we are so careful on our endothelial side also. And sometimes, if even you have a PC damage at this stage, nothing will happen because we have a nice anterior rhexis,
Yes.
which will allow us to put the lens in the sulcus and capture the lens in the rhexis margin. So nothing. I think the most important thing as a surgeon is don't lose your cool, because nothing is going to go wrong with the patient, because we are going to do our best job for him.
So which company sodium hyaluronate are you using now? Because
We have access to AMO, J&J AMO.
No, but recently it is not available in the country. Very few.
Yeah. We have the inventory, so we have large number of lenses. Sorry, large number of viscoelastic. We do use the Helon GB and Helon 5 also. But 1% is there. We had other options earlier, we had that Hayal earlier from,
We are using, stopgap, that Iludon from
Okay.
IOCare, but no financial interest. But that is also quite good. And also we are using Autogel,
Okay.
Auto Lab. Those are all synthetic, not from natural sources, from bacterial fermentation, whatever the process is. So you are given the other lens, no, this particular case. This is also trifocal.
This is a trifocal lens only, and same design. And gives a very good, as we discussed. And
is this
nothing to wrong on this part. Beta light पे देखते रहना बेटा, huh? Very nice. Yeah. Now we have perfect orientation.
Yes.
Beautifully done.
A lot of learning in this.
Ajay, बिल्कुल सही हो गया. You've been very cooperative.
But sometimes in topical, if you take longer time, then probably you need to give sub 10 on block.
Yeah, that I have to learn how to give, I have not
sub
done
10
it.
on is wonderful because sometimes you never know that you may land it into the PC rupture or what you are telling.
Yeah.
Then naturally, if you
So I have to
go
get this
beyond
lens
30
centered
minutes
now.
or 40 minutes, the patient will be those kind of pain and agony. And so sub 10
Light में
on
देखो,
is
सीधा light में देखो. Very nice.
wonderful. So it just take 1 minute more extra time, but very good.
वो देना मुझे intracameral we are putting again. And little on the surface.
Hello.
Then hydrating the wound with the Vigamox only. Little bit of hydration. I'm trying to 3 light के बीच में देखना. Good. The central disc is right up the center of coaxial light. Okay, done.
Thank you. Wonderful surgery. And wonderful demonstration, lively, that how, and not taking much time, you just manage so beautifully. That is the most efficient, of the surgeon and our learning today, all the viewers whoever I mean, excellent piece of demonstration.
हो गया सर,
of
बढ़िया हो गया.
report.
Technology helps you, but at times it lands you in trouble. And that time your real skills
But-
comes into play.
So you have to see these also.
Yes,
life
I think
you
it's
have to
a
learn all
good
these
learning
things.
to be always
Okay.
prepared to manage any unexpected event and have a good presence of mind. And that was an excellent demonstration, sir.
TTL, I will take your leave. I'll have to go to airport.
Okay, thank you, Basak.
Okay,
You have
guys.
been,
Can you
the
guys hear me?
true alumni of this center for getting, everything done, and you have been a teacher to us also. And thank you again being with us. Wish you all the best. Wish you best for the family also.
Thank you. Thank you.
Take care. Take care.
Okay.
So you saw this scenario of cataract surgery. You saw the various cataract surgeries. Every surgery has to be done in a manner where patient outcome is the prime important.
Yes, yes. Cataract is our bread and butter. And naturally, this year we have done, you have seen the thing, we have done 85,000 cataract. And all private.
That's a
no
huge-
charity.
That's a
So
huge.
we do everything.
That's
Thank you.
That's a huge number, Basak. And yesterday I had Disha people like you, and we have the AAC people like or Arun Singhvi and all. Next alumni meeting will be sponsored by you people.
Our pleasure.
Okay, thank you.
Okay, thank you.
Okay, we are shifting to the next surgery now.
Can we, should we? Should we, can we, I mean.
Sir, it's everything is yours decision now. You
he-
can.
He must be talking to Dr. Tityal only. He said everything is yours.
Case that
No,
we
no,
have
is
here
anybody out
is
there?
a 33-year-old
Yes, sir.
male.
Okay, it's for me, right?
Definitely, sir.
That's unit 1.
Yes, sir.
All right.
Unit 1, Professor Coker.
I came in the morning and I was not out batsman. I came back again for batting. So thanks, sir. Shall go ahead with the summary. It's a soft cataract. Summary.
Yes, sir. We have a 33-year-old male who presented with the complaints of diminution of vision in both eyes since last 5 months. The patient gives a history of usage of on and off oral steroids for myositis for the last